Uh, Nikhil ji, for your initial.
Yeah. Thanks. Thank you, Dr. Manish. And thank you, everyone. Very warm good evening to everyone attending today's ISAR Catalyst event. I am Nikhil Mehra, Vice President and Head of Women Health Business Unit at Universal Nutrascience. As many of you know, a quick word about UNS. UN has been a leader in nutraceutical space for over 3 decades, dedicated to developing world-class brands. And thank you for the support of leading experts like you. We could able to establish leading products such as CoQ and Primosa and continue to innovate science-driven brands like CoQman and CoQFam. It's my pleasure to welcome you to the fourth series of ISAR Fertility Catalyst, a collaboration event which we honored to have with ISAR. This series allows us to connect meaningful with India's leading fertility experts. And I extend my sincere gratitude to ISAR President Dr. Amit Patki sir for his invaluable support and to our dedicated conveyors Dr. Anu Agarwal ma'am and Dr. Fassi Lois sir for their efforts in making each section a grand successful one. So tonight we are privileged to also have Dr. Sunita Tandulwatkar ma'am, President-elect of Foxy and our chief guest Dr. Sujata Kar, Vice President of ISAR as our guest of honors. Also, my heartfelt thanks to our esteemed speaker, Dr. Rupin Shah. We all know who is Dr. Rupin Shah, and of course, Dr. Amit Patki sir, who has taken ISAR to the newer heights. And of course, to our moderator, Dr. Kunj Mohiddin. We look forward for an insightful session ahead. And thank you all for joining us. And let's make this another impactful event, a grand and mega successful. Thank you so much. And over to you, Dr. Manish. Thanks.
Yeah, thanks a lot, Nikhil. Let me just take a pointer. What I'll do is share a bit about this webinar which we are having. In fact, this is the fourth in the series, as Nikhil highlighted. And I'm Dr. Manish, part of the Universal Nutriscience team, head of the Medical and Regulatory Affairs. In fact, this webinar, which is on all about male infertility, we have a galaxy of speakers and star doctors across this field who will help us understand this male infertility. Just to share, in today's webinar, we are not going to discuss the beauty secrets of Kim Kardashian, who uses this sperm for her facial work. Neither will discuss the famous song of Aerosmith in the movie Armageddon, but we will touch briefly on spermageddon or the spermocalypse. And as we know, we see reports daily of sperm counts declining, which has been confirmed in several meta-analyses also about this decline in the sperm count. So sperm count, it is not about the quantity, but also the quality which affects the family as a whole. So with this, I'll just give a brief glimpse of Dr. Anu Agarwal ma'am, who hails from the holy city of Varanasi. She is the director of Vanch Fertility and Test Tube Baby Center. She is the national convener for this fertility catalyst webinars, which we are hosting along with ISAR. We are also blessed to have Dr. Fassi Lewis as a national convener, along with Dr. Anu Agarwal ma'am. He is a professor and HOD at Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences. He has a host of achievements to his credit. With this, I'll pass on to Anu ma'am and Fassi Lewis for further proceedings.
Thank you, Dr. Manish. Good evening to all esteemed faculty and doctors who are watching this fourth series of ISAR Fertility Catalyst, all about male infertility. Me, along with my co-convener, Dr. Fassi, we are honored to welcome you all in this series. First, I would like to acknowledge ISAR President, Dr. Amit Patki, ISAR Secretary, Dr. Aisha Bakshi, President-elect, Dr. Sunita Tandulwatkar, Vice President, Dr. Madhuri Patil, Second Vice President, Dr. Sujata Kar. We all know that male infertility is on rise, and I'm sure in this webinar, we all will clear our doubts about this topic and our patients will be benefited. First of all, I would like to invite ISAR President, Dr. Amit Patki, to give his blessings. Over to you, sir.
Hi, good evening, friends. And it's a pleasure to be part of this fourth series of ISAR Fertility Catalyst. I think it's a catalyst to our brain because we get such good speakers and faculty. And I'm so happy that Dr. Anu and Dr. Fassi are the national conveners because they put in a lot of effort, and that is visible with the numbers of registrations that are that are continuously rising for this webinar. So thank you, Dr. Anu and Dr. Fesi, for being such great support. And I also wish to thank Nikhil, the BU head for UNS, and his wonderful team, and the medical side being led by Dr. Manish Garg, because they give fantastic inputs. And as Dr. Sunita rightly said, they are in touch with each and every faculty to ensure that this program goes well. Male infertility, I'm not going to take much time, but it is the theme for ISAR for this year, including paternal aging. And we could not have had a better speaker in Rupin Shah, who is a leading andrologist for male infertility. And I'm glad that he has consented to talk to us. And I'm also looking forward to Rupin, along with Ranjit Ramaswamy, leading the ISAR masterclass in mid-December in Mumbai. So thank you once again to all the faculty, and I'm sure this catalyst will ignite our brains to think and help our patients in male infertility. Thank you very much.
Thank you, sir, for that insightful words. And with this, I invite our ISAR secretary, a very vibrant secretary, Dr. Asha Bakshi, to give a pearls of wisdom.
Thank you, Fesi, for the invitation. And I'm really glad that this program is going so well. And even previous programs, the viewership was so high. And even this time, the registration is so high. And the topic of male infertility, which has been the theme of this year, is really excellent, because that was a little bit neglected. And I think this is the demand of time. And Dr. Anu and you are really doing great job. And today I'm really glad that you have selected very good faculties, and especially it is like a dream come true to listen to Dr. Rupin Shah, who is so very knowledgeable in this particular field. I think he's the best person to get knowledge in this field in our country. And it's so nice to see Dr. Sujata Kar and Dr. Sunita Tandulwarkar. Dr. Sunita Tandulwarkar, who is the chief guest. So I welcome her, and I think we should not waste any more time, and let's go ahead with the academics.
I think with this, we invite Dr. Sunita Tandulkar, who is our ISAR president-elect, also the Foxy president-elect, to give her pearls of wisdom.
Hi, good evening, good evening. First of all, congratulations, Amit. You are doing amazing work, and I'm so happy that you chose male infertility to be your main highlight of the year. Obviously, we all know its importance, and you are rightly helped by certain pharma, mainly this company with whom you are starting this catalyst program. Mr. Nikhil Mehra, your team is fantastic. Dr. Manish and all visiting all the way just to be there. I'm so used to attend the webinars where I'm 5 times, 5 places chief guest, and 2 places they collide. I don't join. Whichever I feel interesting, I join. It is not taken very seriously. And frankly, that's the reason in my Foxy year, I have stopped all the webinars of the chairperson. That is the highlight of my year, because webinar just happens and there is no attendance. The speaker keep on talking so beautifully because speaker has to prepare, but there is no attendance. And the way you people have done the webinar, when Dr. Manish said, Madam, flyer banane ko hi 8-10 din lag jate hai. I was thinking in Foxy, people make a flyer in 8 minutes, not 8 days. They just take the photograph without the permission and they keep on putting. So I'm obviously, these webinars and catalyst, my suggestion, of course, should be that these should be given, the links of these, the timings are the consulting timings of the consultants. So these webinar links you should be giving, and Amit can put it on a broadcast, especially today's, I don't know, I did not attend, but today's when it is a male infertility, even I want to tag around, because hearing Rupin, so many times I have heard semen analysis from him for last 20 years, but every time I feel it's worth listening, waiting, and learning something new. Amit is covering DNA fragmentation and then the interesting case discussion. So I decided that I will be just waiting and hearing this. That's only because of the rich scientific material and the faculty. So I really, I'm thankful to you all for having me as a chief guest here. I think it's in the history of India. Foxy elect and ISAR president elect, though elect position, I don't think this will happen anymore. But I'm lucky that because of whatever position you involved me, and I got to see this beautiful webinar, which will always help me for my academic. And immediately I sent to all my fellows, tuck, on all my broadcast while you all were talking. So thank you once again. And let's start. I think Sujata is also here, but I just wish you all the best.
Thanks a lot, ma'am, for your valuable feedback. Having you is privilege to us. Thank you very much, ma'am.
Ma'am, one thing, ma'am, this flyer is in ISAR broadcast group also. We have shared in that group also.
You know what? There are people like me who are not going on a WhatsApp. So I am deprived of many things today because you involved me as a chief guest and called me at least 5 times. I remembered, I joined, and of course, I'm here to get benefited myself.
Thank you, ma'am.
Dr. Anu, so
Yeah. So our today's guest of honor, Dr. Sujata Kar, beautiful Sujata Kar ma'am is here. Ma'am, we would like to hear from you also, some pearls of wisdom from you.
Thank you, Anu. Thank you so much, Anu, Fesi, and Amit, everybody, for giving me this opportunity to be here today. I was very doubtful whether I'll be able to join in or not. And I don't think I'm visible also properly. But Anu, you've been doing a great job. And I'm so happy that so much work and so much, I'm losing track of so many activities is happening through ISAR. I'm really getting lost as to what is happening, who's doing what, but they are all fabulous and doing very well. I think Amit should be congratulated for that, like Sunita rightly said. But I don't want to waste any more time of yours. Fabulous webinar. All the best, and hoping to see you again soon. All of you.
okay, thank you. Thank you, madam. I think with this, we will go to the scientific session. I think we have the first session by Dr. Rubin Shah. Before that, we will call the chairpersons. We have Dr. Ledika Agarwal. Can you show the slide? Okay. Dr. Ledika Agarwal is a consultant obstetrician and gynecologist and a senior gynecologist practicing at Bareilly and associated with the world-renowned Rainbow Hospital Agra since 2013. And she is the member of UP State Council and currently holding portfolio as Secretary UP ISAR. Because of lack of time, we will be introducing only shortly. And next is Dr. Jayakrishnan. Sir is the Director and Chief Consultant of Reproductive Medicine, KJK Hospital, Trivandrum, with 12 years experience in medical college and 25 years experience in private IVF setup, and performed more than 14,000 endoscopic surgeries and more than 5,500 IRT procedures. And next, we have Dr. Jairani Kamaraj. She is a senior consultant in reproductive medicine and fertility and sexual medicine expert from Agas Fertility Center and Hospital at Chennai. And she is associated with so many associations, Associate Secretary of World Association of Sexual Health, immediate past president of Chennai OBG Society, Vice President of ISAR, and Joint Secretary of Tamil Nadu Federation of ONG. And over to the chairpersons to introduce the speaker, Dr. Rubin Shah. Chairpersons.
Dr. Rupin Shah. I am proud and privileged to introduce Dr. Rupin Shah. He is one of the experts in India, and I know him very well. And he's MS in General Surgery and MCH in Urology from Bombay University. First urologist from India to have training in male reproductive microsurgery, and associated with several IVF centers, has a vast experience in sperm retrieval, and he has developed the Shah penile processes and won numerous orations and awards, including prestigious Dr. B.C. Roy Award from President of India, the founder president of SASSM, the South Asian Society of Sexual Medicine, and senior advisor to Global Andrology from GAF. So, stage is all yours, Dr. Rupin Shah. You can start your talk.
Thank you very much for this very warm introduction. Thank you, Dr. Fesi, Dr. Anu, for inviting me. It's always a pleasure to be part of an ISAR program, which is always very well organized, well attended, very interesting. And I'm flattered to have Dr. Bakshi, Dr. Tendulwarkar in the audience. I've known them for many, many years, and very nice to have Amit speaking after me. So my talk today is on something which is basic and essential, but I think which is very important in being able to understand the infertile male. So I'm just trying to get the full screen and we'll get started. Okay, can you confirm that I'm visible and audible, the slides?
Yes, sir, you are visible, audible.
So the talk today is going to be on how to counsel, or what is the next step after a semen analysis report. And I'm going to divide this talk into two parts. The first is to do with what is new in the latest WHO manual on semen analysis. How has it brought about one very remarkable change, which should actually change the way in which we look at and think about male infertility. And in the second part, we will take each individual component of the semen analysis and see how that dictates or teaches us or tells us what should be our next step in the evaluation. So there's going to be no treatment discussion here, but this is the very first step that we'll be talking about in a semen analysis. And the very first reminder is that the first step in the evaluation, not just of a man, but of an infertile couple, should be the semen test. Now, I've been using the slides for 30 years. I'd hoped that I could stop using this slide. Unfortunately, even today, I see couples coming to me where they'll say, oh, my gynec gave me 2-3 cycles of stimulation, and then we did one IUI, and then when there was no pregnancy, then they asked my husband for a semen test, and the count is only 2 million. I think that we have to now avoid. Absolutely one of the very first things a couple should do before any intervention is a semen test. How many days abstinence? That varies from 2 to 7 days. When the WHO data was collected for the 5th manual, that's 2010, the prescribed abstinence for the volunteers was 2 to 7 days. However, if you look at the practical frequency of intercourse that couples have when they're trying for a child, usually it's every alternate day, and therefore 48 hours to 72 hours would be the correct abstinence for doing a semen test. But also bear in mind that for a given patient, sometimes a much shorter abstinence may be better. So in general, if the abstinence is just 12 hours or even less, the DNA fragmentation, and Amit is going to talk about that, would be lower. So if somebody has good count, good motility, can give a sample. We will very often ask for a short abstinence. And the other way around, somebody with no living sperm and one ejaculate, very often if they give a second ejaculate, just a couple of hours later, you might retrieve motile sperm in that. That said, let's talk about how to interpret the semen analysis. And this was always done with the WHO norm. And the 5th edition that was published in 2010 gave a sperm concentration of 15 million per ml or 40 million total with 32% progressive motile. And this was rapid progressive and slow progressive combined, and 4% normal morphology. Now, often I've had gynecologists send me patients that 90% is abnormal and we are worried. That's not a cause of worry at all, but I'm going to talk about morphology some more, which I think would be of interest even to well-experienced IVF specialists, because the current evidence suggests that the current way in which morphology is evaluated, it has lost its predictive value, and we'll talk about that further. But now let's come back to the norms. The 2010 norms were derived by looking at a population of 1,800 men, all of whom had fathered a child within 1 year. The values were distributed, and the 5th percentile was taken as a cutoff between fertile and infertile. It's important to know this because often people quote this figure as something sacrosanct, that if it's 16 million, they're fertile, and if they're 14 million, they're infertile. Not at all. This is just a probability distribution. 5% of fertile men had counts lower than this. And if you look at the 50th percentile, which would be what the average number of fertile men had, the count, motility, morphology was much higher than the so-called norm. And for reasons that we will see later, remembering this is very important when we interpret a semen analysis in this day and age. Now, the problem with the 5th edition was these 1,800 men came from a biased North population. South America, whole of Africa, whole of Asia, not represented. So for the next 6th edition, 5 more countries were added. So there was some Africa, Asia through China, Italy, and the number went up from 1,800 to 3,500. But interestingly, when they recalculated for 3,500 men, the distribution, and went to the 5th percentile, they found that they're virtually the same. If you look at the two columns here, WHO 2010 and WHO 2021, it's virtually the same count, motility, morphology, so that even if you're following the old norms, they probably don't matter. The only major change in these norms with the 6th edition brought about was in progressive motility. In the 4th edition, the manual distinguished between rapid progressive and slow progressive. In the 5th edition, they said that it's very difficult for embryologists to make this distinction, and therefore they dropped it. But in the 6th edition, this was brought back. So the A, B, C, and D category. So again, progressive motile, they recommend be divided into rapid progressive and slow progressive, because the evidence suggests that the presence of rapid progressive sperm correlates better with pregnancy. So knowing this has implications for the lab and for the clinician when they look at a semen report. You could have 2 reports with 40% motility. One report is 40% all grade 2, which is only slow progressive. And the other one could be 10% rapid progressive and 30% slow progressive. And the second sample would be considered more fertile. So this is something to bear in mind. Now, what is the most dramatic, however, is this statement in the 6th edition. And I'm going to read it verbatim because it's very important. It says the lower 5th percentile, which we just quoted in the reference population, does not represent a limit between fertile and infertile. Now, all clinicians have known and seen this. Everyone has had patients with 1, 2, 3, 5 million achieving a pregnancy and others with 20, 30 million not achieving a pregnancy. But till the onset of the 6th edition, we perpetuated the myth that there is a cutoff below which men are infertile and above which they are fertile. Finally, in the 6th edition, they bit the bullet and came up with a firm statement that these reference ranges cannot be used as a distinction between fertile and infertile. For an individual patient, or more accurately, individual couple, a semen analysis is never prognostic. I wouldn't say never, but usually not prognostic of fertility potential, because that depends on many more variables. And therefore, you have to use several parameters and not just look at the semen. The clinical implication of this is very important, and we look at that once we see what are the other parameters that we need to combine with semen. So we don't have time to look at all the data, but there's a fair amount of data that the duration of infertility, the trying time, acts as a wonderful filter to distinguish between fertile and infertile. So you could have two men, both with 5 million sperm count, 30% motility. One man is young, wife is young, trying time is 6 months, and the other one is 35-year-old and has been trying since the last 10 years. The first young couple still has a 1 in 4 chance of a natural conception, even though the count and motility are so low, because many studies have shown that in the first 2 to 3 years of marriage, especially with a young couple, semen analysis has only a poor predictive value of which couple will get pregnant. And we see that when couples come for secondary infertility. The man had 5 million 10 years ago, he has 5 million now, but 10 years ago, his wife was 25, she conceived naturally. Now she's 35, and with the same semen parameters, they've been trying for 2 years and there is no pregnancy. So we know that in addition to the semen analysis, we need to know duration of infertility. We need to add the female age, because in all studies, the strongest predictor of pregnancy beyond all other parameters has been female age. And I see more and more younger women coming with low AMH. So in such situations, we need to not just look at semen, but also the female partner in trying to decide what should be the next step. And finally, whether there is a female factor that is preventing a pregnancy. Some of my gynec friends don't look at the male, but some of them do the opposite. They look at the male, they see a low count, and they tell me, Rupen, until the count motility improves, we will not correct the wife's ovulation. That too is incorrect. It has to be a common joint management, because the fertility potential depends on all of this. So once we bear this in mind, then we can realize that just looking at the semen in isolation will actually be misleading. So in the 6th edition, the role of a semen analysis has changed. It's not to tell you fertile versus infertile. It is one of the contributor factors to assessing male fertility potential, where the semen analysis plus duration of infertility plus female factor all put together then allow us to assess the fertility potential of the male and even more so of the couple as a whole. Semen analysis also has another very important role, and that is depending on how the parameters have altered. Are they towards the lowest we should be doing as the next step in our evaluation. And of course, finally, it would help us choose whether we wait for natural pregnancy, do IUI, or opt for IVF-ICSI. So now let us look at each individual parameter. Low volume, the manual says less than 1.5 ml. And for the Indian population, I found that 1 ml is a more accurate cutoff. So if it's less than 1 ml, I consider that low volume. Low volume has great significance. But before we jump to that, you have to make sure that there was abstinence. Sometimes the man has abstained for 5 days, ejaculated in his sleep that night, and 4 hours later he gives a sample and the volume is low. So we need to inquire into that. Often there is spillage because they're nervous, not comfortable, and that needs to be ruled out. And sometimes it's an incomplete ejaculation. Now, if all these have been ruled out and the semen volume is low, 9 times out of 10, even before I examine the patient, I know I'm going to find a case of bilateral absence of the vas deferens. And this is important. I remember going once, I think, to Ludhiana or someplace, and there was a couple married 7 years, azoospermia, no treatment given, and he had 5 semen samples all showing 0.5 ml azoospermia. I told the doctor who was with me, let's examine. It's going to be vas aplasia. So the diagnosis was staring you in the face, and for 7 years, it wasn't picked up. If the vas is palpable and the volume is low, then the diagnosis is ejaculatory duct obstruction, but that is far less common than vas aplasia. Vas aplasia is surprisingly common and often missed. So if you have low volume, you need to have the patient examined by an experienced urologist, because the diagnosis of vas aplasia is a clinical diagnosis. And if he clearly tells you the vasa are palpable, then the next step would be a transrectal ultrasound. So in other words, low volume, these are the clinical possibilities, and the next action, if fructose was not tested, to look at fructose and have examination by an experienced uroandrologist. The other finding which is commonly seen is delayed liquefaction or increased viscosity. If these happen once in a while, that's okay. One sample delayed liquefaction, the other one normal. But if this is a persistent finding, it indicates an alteration in the secretions of the prostate and the seminal vesicle. This could be due to an active infection at present, or even a past infection, which can result in a longer duration change in the secretory qualities. So if the report is showing either of these two, your next step would be to look for either a history of urinary tract infection or current findings physically, or investigations like culture for looking for infection. Similarly, agglutination, once in a while, 1+, 2+, doesn't matter. But if recurrently we see agglutination in multiple samples, 3+, 4+, again, it tells us there could be infection or antibodies, and our investigation has to be, once again, through history, examination, and evaluation to look for past or present evidence of infection, primarily of the prostate and seminal vesicles, and also do an antibody test if available. But the antibody test has to look for antibodies on the sperm surface, not an ELISA test in the serum, because that is not diagnostic of any form of immunological infertility. Low count, very, very commonly seen. It may be isolated low count, but usually it's oligoasthenoteratozoospermia. In the presence of repeated low sperm counts, it's an indication that this patient once again needs to be referred for a proper examination. Many ART specialists or gynecologists think that an ultrasound is a substitute for a physical examination. It is not. The diagnosis of varicocele is a clinical diagnosis. If a man does not have a clinical varicocele, but an ultrasound picks up reflux, that is of no significance. So the first step has to be a physical examination, and only some of those men may need an ultrasound. You would need a detailed history to look for gonadotoxic factors, lifestyle changes, major medical illness, recent illness, high fever, all of which may be correctable causes. Now, if there's impaired motility, it could be as part of the oligoastheno syndrome, in which case it is as I talked about, or it could be in isolation. Now, if you have good count but impaired motility in isolation, then it becomes tricky. Again, you look for evidence of infection and antibodies. But if it is severely impaired, 0%, 5% motility, or total asthenospermia, then that tells us that in this sample, we need to do an eosin nigrosin test or an HOS test to distinguish between live immotile sperm or dead immotile sperm. Live immotile sperm could be due to cartilaginous syndrome or microtubular defects, but these are still viable sperm and they can be used for ICSI after picking them up using HOS. But if the majority of sperm are dead, that is necrozoospermia, and there we should be taking testicular sperm because they will still be viable. Usually the cause of the necrozoospermia is death of the sperm during transit through the epididymis or due to the accessory gland secretions. In fact, in some cases where there was 0% motility in the ejaculate, we've had motile sperm in the testes. So differentiating between the two, very important. Now, here is something that I want to spend some time on because I find a lot of my IVF colleagues are stumbling here. The two types of teratozospermia. Monomorphic means all sperm have the same defect. So 99% pinheads or 99% round heads. That's a genetic cause. Nothing can be done for those patients. Most of the times when there's teratozospermia, it's polymorphic. Polymorphic means that there'll be some head defects, some mid-piece defects, some tail defects, and all of them put together by strict criteria. If more than 4% are normal, the sample is considered normal. The problem is nowadays, the majority of reports that you will get from an IVF lab will show normal morphology of 1%, 2%, 3%. And I've seen numerous patients being counseled that your morphology is only 1%. In fact, 2 hours ago, I was reading an email from a patient. My morphology is 1%. My gynac has said that only IVF ICSI will work. Don't wait for a natural pregnancy. So let me show you 2 papers. To the left is a paper that I published with my UAE group, which looked at, I think, 1,500 IUI cycles, and we found that strict morphology did not predict whether IUI succeeded or failed. So in other words, men with 1%, 2%, 3% normal forms, 98, 99% abnormal forms were still succeeding in IUI, almost as well as those with much higher morphology. And to the right is a paper published in June this year in Fertility, Sterility, which reports that 55% of fertile men had teratozospermia defined as 1, 2, or 3% normal sperm. So what is happening here? What is happening is that little by little, morphology assessment has become so strict that it has lost its discriminatory ability. And many fertile normal men are also being labeled as teratozospermia. There is a systematic review by Ranjit, who will be doing the workshop with me mid-December, and many other papers published, all showing that morphology, by the ultra-strict criteria of the 5th and 6th WHO manual, has lost its predictive value. So the very important take-home message is if you see poor morphology, 1%, 2% in the semen report, you should not worry about it. It should not affect your treatment decision. It should not make you scare your patient, or don't let your patient worry about having a 2-headed baby. Interestingly, as we have shown in our paper, it's open access if you want to read it. If you look at papers which use the 4th edition of the WHO manual, where morphological criteria were not as strict, in those studies, morphology was predictive of outcomes, suggesting that truly it is the method. So my feeling is in the 7th edition, the way in which morphology will be evaluated will have to be changed because currently it has lost its meaning. And finally, one last message, and this has to do with pus cells. Now, this is an old slide of mine, but I still continue to see this issue. 15 to 20 pus cells in the semen, patient has been given antibiotics for weeks and months, semen culture has been done. And when they finally come to me because the pus cells are persisting and the culture is persistently positive, we do two things. One is we repeat the semen test with staining of the slide. And I'm going to show you what that does. And suddenly we find that there are no pus cells. And when we send the semen for culture, we give instructions which are normally not given. So I'm going to repeat them here. Any patient who goes for a semen culture has to follow these instructions. He carries a bottle of betadine with him, povidone iodine, we don't want a brand name, and boiled water. In the lab, he cleans his penis with the povidone iodine, pulls back the foreskin if he's not circumcised, cleans the glands, washes his hands with the same solution, keeps it on for 5 minutes. During that time, he goes and passes urine, so the anterior urethral commensals are washed out. Then he washes the penis with the boiled water or saline that he's carrying, and then gives a culture. 80% of persistent positive cultures that are referred to me get cured simply by repeating the culture with these precautions. And one step before that is, as I mentioned earlier, staining the slide. Too many times pathologists look at only a wet prep, and in a wet prep, you cannot distinguish between these three types of cells. The leukocyte, which is truly indicative of infection, the macrophage, which is not a sign of infection, which is normally present, and the primary spermatocyte, which is also normally present. So if you follow the manual, one should use peroxidase staining and report only on peroxidase positive cells as leukocytes. And if that count is more than 1 million per ml, then that is considered infection. If that's not available, then an H&E stain to distinguish between these. And a large number of so-called pyospermics will disappear and be reported as normal if this precaution is taken. So with that, we are coming to the end of this overview of semen analysis and its clinical implications. Semen analysis, of course, is the first step, and it is useful, but you also need to understand its limitations. One, it has to be performed correctly. Many labs are not well trained. There can be huge variations. So wherever possible, one needs to make sure that you have a lab that is having a trained person. The correct interpretation, as we saw, semen analysis is a probability indicator. It does not have a clear-cut line below this infertile, above that fertile. The higher you move down the normogram, the more likely the couple is to be fertile. If I have someone who is at the 5th percentile and is labeled fertile, I still want to move him to the 30th, 40th percentile because that will increase the chances of conception. And of course, it's useful for monitoring therapy, whether you're giving medicine or operating a varicocele. Comparing the semen would guide us. So once again, thank you very much for inviting me to be a part of this wonderful meeting. And I'm certainly looking forward to the next very important talk on DNA fragmentation, which is really now the one sperm function test that needs to be added to a semen analysis.
Thank you, sir, for that crisp and clear and overview of semen analysis. Over to chairpersons for the further discussion.
Thank you, sir. Thank you so much for throwing a lot of insight about all the male factor, how it is as a evaluation, the interpretation of the reports, and how it has been evolved. And right from the beginning, all your insights about the WHO classifications, how we should interpret, and from the gynec perspective, what we should do. All these things are really very good on your side, sir. And regarding the morphology, what you said was absolutely very much interesting. And very interestingly, we also come across very many patients with secondary infertility who conceived in the younger age with the sperm count which is lower, but when they come later in the life for the second baby, they have a lot of issues in conceiving. And when we look into the semen parameters, that shows obviously it has been on the decline. So always when a woman's fertility is very good, a single sperm can give a pregnancy. So that is the moral that we learn when she's young, when she have her fertility very good, even with a low sperm count, they can get a pregnancy, sir. So thank you so much for throwing out a lot of insight about everything regarding the evaluation of the semen analysis. And we are really very much, your knowledge, your experience and your expertise has really made this a very interesting one, sir. Thank you so much, sir.
Thank you.
Jason, sir. Mute, you are mute, sir.
Hello, sir. This is Dr. Pooja Mehta from Chandigarh. Sir, first of all, thank you so much. It was a wonderful talk. I mean, of course, it is always a pleasure listening to you, sir. There's one question, a person with retrograde ejaculation, how do we instruct them, to give the sample? At times, the volume of the urine is so much. Then how do we instruct those patients, and what is there some trick of telling the patients that do it this way, So I just want to hear your view about that, sir.
So you need to know why they have retrograde ejaculation. I'm always asked this question, and it makes me think people are seeing it a lot, whereas I actually don't find it a very common problem. But if there is retrograde ejaculation due to type 1 diabetes, which is the commonest cause in young men, that is a neurogenic failure of the bladder neck, 50% of those patients, if you treat them for 3-4 days with a sympathomimetic and an anticholinergic, ephedrine was ideal, but it's not available. So we give any of the cold medicines with either pseudoephedrine or phenylephrine together with imipramine at night. 50% of them will convert to an antegrade ejaculation. Now, in those cases where it is not due to diabetic neuropathy, but say either trauma to the bladder neck or some injury surgically or otherwise, there the medicine won't act, and there we have to recover sperm from the bladder. And that can be recovered in 2 ways. One, by making the urine very dilute and alkaline, or 2, by emptying the bladder of urine and instilling media in the bladder. The first is easier, so we try the first method initially by giving them soda bicarb, citralka, potassium citrate 3-4 times a day for 3 days. Keep on checking the pH, and once the pH of urine goes over 7.5, ask them to drink a lot of water, and then they masturbate. The sample flows into the bladder. Immediately they void the urine. Time should not be lost. The lab should spin the sample, separate the pellet, rewash it in media, and see whether you have adequate count and motility. If you have good count, good motility, you can use that. If you have good count but poor motility, despite an alkaline urine, then we use an alternative method. We would ask the patient to void his bladder, then catheterize using liquid paraffin, wash the bladder once with soda bicarb, drain it out, then instill 30 ml of sperm washing media in the bladder, remove the catheter, ask the man to masturbate. Once he reaches an orgasm, he voids the medium, and that is again spun to recover the sperm. And usually that will give much better motility.
Okay, sir. And about the first thing which you said, in the last week only, sir, I saw 2 patients who were diabetic, not in control. Of course, I told them to get his sugar levels into control. I have referred him to an endocrine specialist. But the thing is, sir, like about the medicines and drugs, do we refer them to a neurologist for that?
Neurologist will have no clue.
No, exactly.
It has to go to the uroandrologist. And now you
Actually,
know.
I need to refer them to you, sir. I need to refer them to you then.
No.
Yeah.
Now you know what to do, so you don't need to refer to anyone.
Oh, but then, sir, as a gynae, can I just prescribe them these medicines?
Prescribing is fine. If you ask me, can I do a TISA? I'll probably say no, but prescribing medication, yes.
Okay, fine. Okay. Thank you so much, sir. Thank you so much.
Nice to see you, Pooja.
Yeah, thank you, sir. Same to you, sir. You can see me now. I was walking out, I had to go somewhere, so that way you won't be able to see me also. I'm in dark, Thank you. Bye. Nice sitting. Thank you so much.
As always, a very lucid lecture. Just want to ask you a quick question. Occasionally, we find some semen volumes are very large, more than 6-8 ml. Is there any significance to that?
So thank you, Amit, for that comment. And yeah, if a man has had prostatitis or has prostatitis, very often the prostatic secretions increase in volume. For some men, we see large volume, but no evidence of infection. So maybe that's just the way they are. But when you have large volume, that's one of the indicators, not a diagnostic parameter, but an indicator that look for past or present infection.
Okay, thank you.
So one more question.
Hello,
Sir,
doctor.
what is your opinion regarding antibiotics, sir? Do you rely on culture report? You give antibiotic only after positive culture report, or you give sometimes empirically also? And if
So,
yes, which and how much is
many
the
studies
duration?
have shown that empirical antibiotics do not improve either IOI or ART results. If a person has pyospermia with proper staining of the slide, large number of pus cells, then I first empirically give them a course of doxycycline to take care of chlamydia, mycoplasma, which are common and not easily cultured. After that, if the repeat semen still shows genuine pyospermia, then I will send for a culture based on the method that I mentioned, and then give antibiotics, keeping in mind that you would select those antibiotics that penetrate the prostate better, typically from the quinolone group, if the organism is sensitive to that, otherwise whatever is sensitive. And the course of antibiotics for chronic prostatitis is a fairly long course. Therefore, we will not give it lightly. We would like clinical correlation in terms of history, symptoms, physical finding, and lab findings.
Hello, Dr.
Thank you so
Rubin,
much,
Dr.
sir.
Jayakrishan here.
Nice to see you.
Nice to hear you also. Back to
I
the
was in
basics.
Trivandrum this afternoon. I just flew back.
So nice, missed you. So just wanted to ask you regarding the low count 1 million, 2 million. How long will you wait before saying that actually it is a case of a temporary phenomena, or it's actually a low oligospermia?
So, if you're saying temporary, it means that some recent insult has brought it down. So that's a very good question, because there are two aspects to that. Very often a patient will come to me 5 years infertility with his latest report, which is 1 million. He's been infertile 5 years, so I know he's done 10 tests. So I say, where are your old reports? And he says, no, my doctor told me just carry this latest report. I tell him, come back with your old reports. And if all the old reports were 20 million, 30 million, and the recent one is 1 million, I know this is a temporary fluctuation and I expect it to go back up. Supposing this is the first time he's done a semen test, but he says, last month I had filaria, malaria, chikungunya all together, then we would wait 3 months. 3 months is a few weeks over a spermatogenic cycle. So that would give him time to recover and also improve the sperm count. And then if the sperm count has gone up from 2 million to 15 million, then we'll tell him wait. After another 2 months, it'll probably be 25, 30.
Okay. Thank you. Thank you very much.
To continue the same discussion, Rupin, actually Jaya has taken 1 million very low count, but 5 to 10 million, if there is no history and all, with the advancing age, we do expect the male semen parameters also getting deteriorated.
So age is a critical factor. A 35-year-old couple will have very different prognosis, and our counseling will vary accordingly compared to a 25-year-old couple. Certainly.
Absolutely.
Dr. Latika, any questions?
Sir, if I may ask?
Yes.
Yeah, Dr. Parisham here, sir. Sir, regarding, you just spoke about age. I think there's been a lot of emphasis in the last few years saying that the semen parameters or the semen quality decreases over the years, probably reduced quality over the years. And so higher, the older the men are, probably the results are less. But if you contrary look at the kind of results that we get in our IVF cycles, obviously the best cycle results are mostly in donor egg patients, obviously, because we're using very good eggs and the sperms. Is it actually there, or probably that a reduced sexual function that is causing that is probably the reason of a decreased quality rather than an age-related decrease in quality of these sperms.
Perhaps Amit may have a slide showing that the incidence of DNA fragmentation goes up after the age of 40. So there is an age-related change in quality more than count and motility. But nature is kinder to men than women. The deterioration in men is very gradual, not predictable, depends on their lifestyle and general health. Unlike women, where around 40, their fertility is completely plummeted. And we know also that if you have young, healthy eggs, then DNA fragmentation index doesn't seem to predict pregnancy outcome, because the egg can actually repair the sperm and give an adequate pregnancy. So if you're looking at donor eggs, it probably compensates for the minor degree of male infertility.
Thank you, sir.
So one more question, sir. How can we differentiate an anejaculation from a retrograde ejaculation, sir? Very sometimes resistant anejaculation. How we can differentiate both, sir? Sometimes
I think that's the important question, because I suspect often cases of anejaculation are wrongly diagnosed as retrograde ejaculation. When a man says, I'm not producing a semen sample, you need to ask him, do you reach an orgasm and don't ejaculate? Or are you not reaching an orgasm? If it is an orgasmic anejaculation, then it's not retrograde ejaculation. He's not reached an orgasm, and that man needs to be treated with vibrator stimulation. On the other hand, if he says clearly, I reach an orgasm, I have a pumping sensation, but nothing is coming out, then the post-orgasm urine has to be checked for sperm. If it shows sperm, it's retrograde ejaculation. However, a man could reach orgasm, not ejaculate, have no sperm in the urine because there is failure of emission, which means that the spermatic fluid is not deposited in the urethra. Again, the same causes of retrograde ejaculation. If you have severe autonomic neuropathy, there'll be failure of emission. So in severe young diabetics, you won't find sperm in the urine because they have complete failure of emission. So that too can happen. So you need to distinguish between orgasmic and anorgasmic and then take it further. And the diagnosis of retrograde is made only if fair number of sperm are present in the urine, in the post-orgasmic urine.
So thank you so much, sir, for
you
this
very
wise, wonderful deliberation and answering all the questions, and very practically, it is of much use for all the practitioners here. Though we don't have much knowledge about the andrological part, the practical approach is always very important, as you rightly pointed out. Thank you so much, sir, for throwing out all your experience and expertise, sir. Over to Fesi, sir.
Okay. Thank you, sir. Thank you, the chairpersons. Next, Dr. Anu will call the second speaker. Dr. Anu, are you there?
Thank you, Dr. Fesi. Rupan sir, it was a wonderful talk. We'll be going home and sitting on our OPD next day with so many knowledge. We'll change our way of seeing the semen analysis report. So next talk is of sir. Thank you, sir. Next talk is of Dr. Amit Patki. Sperm DNA fragmentation, window to a man's health. And our chairpersons are Dr. Nirmal Bhasin. She's director, clinical embryologist, and founder of Jenny Fertility Center and MD from Minsk State Medical Institute, Belarus. Welcome, madam. And next chairperson is Dr. Pooja Mehta. She's infertility specialist at Fortis Bloom IVF, Mohali, Foxy accredited trainer for infertility courses. And she's gynecologist and infertility specialist, trained in field of ART and endoscopy from Foxy, Mumbai. Welcome, Dr. Pooja. And next chairperson is Dr. Ritu Santavani. She's MBBS, MD, FICOG, FIAOG, AMRCOG, ART from Singapore. And she's a leading gynecologist, keynote speaker, author, and key opinion leader. Welcome, Dr. Ritu.
Thank you, Anu.
I'll request chairpersons to introduce a speaker, next speaker, Dr. Amit Patki.
Yes, I'm Dr. Nirmal Bhasin, and what I would like to say about our speakers, both of them, they are the trendsetters. And in this era where the focus is on male infertility, they have paved the path for us to follow and understand. And now, if I speak about Dr. Amit Patki, apart from his academic knowledge and his expertise, I have known him as a person in the past 1 year when he was the president. He's the president ISAR, and I got to know him closely. And he's a wonderful human being, a very warm person at heart, and very meticulous, very ethical, and we love him. And we are at the same time scared in a way that yes, we have to follow, and he has set a benchmark for all of us, the state chapters, and we have got to learn a lot from him. And now over to Sir for the topic on DNA fragmentation. And we have a lot to learn from you, Sir. Yes, please.
Thank you very much and very good evening to you all. And thank you for your kind introduction, Dr. Nirmal, and to all the chairpersons. Are my slides seen and am I audible?
Audible, but slides not started seeing.
Okay. Now?
Not yet, sir.
Not yet.
So how do I share my slides? 1 minute.
So there's an icon below, greenish share icon.
Yeah. All right.
Yes, sir. Now it's loading.
Yes.
Now it's loaded?
Yeah. Now
Yes.
just need to make it full screen, sir.
Yeah. Now?
Yes, sir.
Yeah. All right. So thank you very much. And I think it's always very difficult to follow after Rupin has spoken, but I will try my best and I will go on to another aspect of male infertility, which is on sperm DNA fragmentation. Rupin has set the ball rolling on routine semen analysis, and I'm so glad he has said that that should be the first test in the couple which has to be done before we proceed for any other test. So semen analysis is an important test for evaluating male infertility, but it does not provide information regarding all functions of the sperm, nor is it sufficient for predicting male fertility potential, because as Rupin said, there are many other factors that need to be taken into consideration. He has also very rightly said that in the WHO criteria, the standards for normal value in the semen analysis are not the average values, but instead are the bottom 5% cutoff, which means that what you read is the minimum standard that is necessary for pregnancy. But as we all know, we have seen pregnancies with counts and motility much lesser than what is predicted. This is a very disturbing trend that we see, that the semen counts are declining all over the world at an accelerated pace. And prior to 1973, the average count would be around 100 million per ml, which in 2018, over 50 years, has come down to an average of 50 million. So the trend of declining sperm is minus 1.16 prior to 1972, and which has become more steep decline at minus 2.6 since the year 2000. So we are having declining sperms globally, and again, there are multiple reasons for it. We know that men in whom the counts are on a lower side have a high incidence of prediabetes, hypogonadism. We also know that if the counts are severely low, there would be high sperm DNA fragmentation and also leading on to non-obstructive azoospermia. We know it is associated with the overall health of the man, and we know that almost 60% of men who have got oligospermia or astenospermia were diagnosed to be overweight or even obese. And the sad part is that men who have got low sperm counts are more likely to have metabolic syndrome, as we see in PCO women in their latter ages having diabetes, cardiovascular diseases, than men who have got normospermic. So if we look at the sperm DNA fragmentation test, is it a window to a man's health? And what got us interested or was an eye-opener was this paper from Ashok Agarwal way back in 2005, which said that 15% of men with male infertility were found to have normal semen analysis reports. And this is a problem because quite often when you see a normal semen report, from then on, your concentration goes only on the female, and quite often they're subjected not only to multiple IUIs, but even to IVF, which also lands up with failure. So reproduction in men is a window for health, and we know that male factor infertility is commonly found in men, or perhaps in men in whom there is likelihood of developing further cardiac, metabolic, or even oncologic diseases. And hence, when you see an abnormal report, I think it is very important to treat the man as a whole, to look into his health and see whether he's pre-diabetic, hypertensive, having some thyroid illnesses, obesity, or even addictions like smoking and alcohol. So when you select a sperm in a case where there is high DNA fragmentation, and particularly when it is used in ART, you can land up with undesirable effects, including low fertilization, low blastocyst formation, decreased implantation, thereby giving you lowest pregnancy success rates. And we now know that recurrent miscarriages can also be because of male factor, and we have started doing sperm DNA fragmentation in such couples. What causes DNA fragmentation, which is multiple breaks in the sperm DNA? One is infections, inflammation of the male genital tract, obesity, varicocelectomy, and febrile illnesses. We also know that there is increase in the oxidative stress, and this can be because of lifestyle disorders, including diabetes, hypertension, and sometimes treatment of these illnesses, exposure to chemo, radiotherapy, and environmental pollutants. So when the DNA fragmentation increases, it gives us suboptimal results in ART, suboptimal embryo qualities, reduced pregnancy rates, recurrent miscarriages. And we now know that especially when sperm DNA fragmentation is combined with elderly men, we land up sometimes having genetic disorders or increased incidence of childhood malignancies, attention disorders, and autism spectrum disorders, but that is another topic for discussion. How do you measure the DNA fragmentation? The benchmark or the standard test is a tunnel test, but it is very difficult to do a tunnel test. It has a very sensitive platform, and quite often tunnel test is expensive and used only under research settings. So the indirect method of measuring the DNA fragmentation is the sperm chromatin structure assay or the sperm chromatin dispersion test, which are most often done by IVF centers. But whenever a research setting, the tunnel test was performed, it is found that the sperm DNA was higher in male partners of couples that experienced recurrent miscarriage, 35%, than in the general population of 22%, or normal fertile men of 12%. So we conducted a study of 100 couples who were referred to us after 1 or 2 IVF failures elsewhere. And we not only did their semen analysis, but also combined it with a sperm DNA fragmentation. And we had almost 66 of them having normozoospermia, but despite that, they had a high incidence of DNA fragmentation, averaging 34%. And in those 33 of whom we found oligospermia, we had a DNA fragmentation which went up to as high as 49%. So when we looked at these oligospermic 33 men, we found that those who had severe or moderate oligospermia, the DNA fragmentation was equally high than those who had mild oligospermia. When we looked at the motility of astenospermia, we found that 9 of them had got astenospermia, and in such men where there was severe or moderate astenospermia, we had a DNA fragmentation which went up to as high as 85%. When we further analyzed these men, we found that 24% of them were over the age of 40. So we know that advanced paternal age is related to sperm DNA fragmentation. We had 21 of them who were diabetic or diagnosed as diabetic with us, 12 of them hypertensive, 4 of them with thyroid issues, of which 3 were hypothyroid and 1 with hyperthyroid. 9 of them had an obesity with a BMI of more than 30. 20 of them had smoking of more than 25 cigarettes a day. 6 of them had alcohol, which was more than 6 units per week. We also had some of them with HIV and HbSAg positive. Varicocele on examination was found in 15 of them, abnormal karyotypes in 2 of them, and we surprisingly had 2 of them who were on chronic medication. One of them was on dapsone, which was prescribed for some skin allergy, and he was taking it without any supervision for a period of 9 years. And we had one gentleman who was on create supplements who had severe sperm DNA fragmentation. So we know that lifestyle modification is necessary even in men. Elevated BMIs, diabetes, environmental and lifestyle disorders like smoking and alcohol are known to increase fragmentation rates. Very simple advice of wearing loose underwears, avoiding environments with hot temperatures like steam and sauna are very simple measures to reduce DNA fragmentation. What about infection? Male genital tract infection is found in approximately 8 going up to 35% in some papers and causes of male infertility. And we know that when there is true male genital tract infection, there is inflammatory cells which produce ROS, which is known to cause DNA damage. So simple treatment with antibiotics in presence of male genital infection, we give doxycycline to such patients for 2 weeks, will reduce the amount of ROS produced, and this will help us to improve the DNA fragmentation, thereby improving the fertility potential of the men. Oral antioxidant therapy was given out of want to give something to these men of male infertility, but we now know that some of them play an important role in preventing or reversing the sperm DNA fragmentation. We know that when there is excessive amount of ROS, if it is not counterbalanced by antioxidants, can lead to oxidative stress, and this can cause lipid, protein, and DNA damage. Now, because oxidative stress is potentially reversible, this gives us an opportunity to treat such men with oral antioxidants, and there are a large plethora of antioxidants which are available in the market. The cheap ones, which are the vitamin C, vitamin E, selenium, and the not so cheap ones are the coenzyme Q, N-acetylcysteine, L-carnitine. but we must understand that all of them singularly or in combination are effective, but we need to give them for a minimum of 3 months to have any sensible outcome of treatment. Let's start with CoQ10 because this is the new kid on the block and it maintains an efficient energy system. It is beneficial for sperm motility, particularly forward motility, and is the choice of therapy for asthenospermic infertility. And we have seen men with improved outcomes, improved semen parameters, and decrease in the sperm DNA when it is given to men with idiopathic oligoasthenospermias. Glutathione deficiency results in dysfunction of the central part of the sperm and results in defective sperm motility, and lycopene increases the semen counts by as much as 70%, and hence it should be a part of your antioxidant therapy. Sometimes ginseng and amino acids are added to a multi-blend therapy because ginseng stimulates spermatogenesis, thereby improves testicular function, and deficiency in L-arginine is known to cause derangement of sperm metabolism, resulting in decrease in motility and loss of spermatogenesis. And L-carnitine is the most effective treatment to improve sperm motility and morphology. Then the group of vitamin B, C, D, and E are also added in some multiple blends. And this is a diagram which I found was very interesting, which showed you which antioxidant and which vitamin worked on either the head, the midpiece, or the tail of the sperm. So having gained some insight on sperm DNA fragmentation, which was found to be increased in some men despite having a so-called normal semen report, we conducted a prospective multicentric randomized double-blind study in 10 centers, each contributing 30 patients with a total of 300 subjects. The semen analysis and DNA fragmentation was done on day 0 and day 90. The inclusion criteria was semen volume less than 1.5, a semen count less than 15 million, rapid motile count less than 25%, and a DNA fragmentation of more than 20%. The primary outcomes were the change in the total count and the change in the sperm DNA fragmentation. And the secondary outcomes were changes in the sperm motility, morphology, volume. We allowed the specialist to continue the treatment. And if any couple concede in those 90 days, we would still request the male to continue the tablets and do a semen test and a DNA fragmentation at the end of 90 days. So we found that there was a change in the total sperm count as compared to placebos, and we found that the change was more effective when the counts were lower than 5 million. So those who had a severe oligospermia did better than those who had mild oligospermia. Now, both the groups, the placebo and the treatment groups, were treated if they had any comorbidities, were counseled for lifestyle changes, and hence, even in the placebo group, we did find an improvement in the semen count. As far as the sperm DNA fragmentation decrease was found, we found that there was an 18% decrease in the treatment group as against a 12% decrease in the placebo group. We also found that in the treatment duration, 25 patients conceived in the study group against 5 in the placebo group. And this was published as an original article in the journal around 2 years ago. What are the other methods of reducing the DNA fragmentation? One very simple advice is to tell your patients to have a short ejaculatory abstinence especially when they are undergoing IVF or ART procedures. Quite often, patients maintain abstinence through the period. So when they give the sperm count, the abstinence averages more than a week to 10 days. And this itself, we know that the effect of ROS in the vas would cause detrimental effects on the sperm. And hence, you should proactively tell the patient not to maintain an abstinence of more than 2 days prior to giving the sample. Varicocele repair, I think this is very important that you examine the men, and only in men where you find on examination of varicocele is it worth offering any surgical treatment. Now, surgical treatment does not give benefit to all men. It is found that when you have a testicular volume which is normal and a turgid testes in presence of varicocele, I think those varicocele repairs will give you a substantial improvement in sperm count. As against where the testes are small, soft, flaccid, the improvement after the repair may not be to your satisfaction. You can also use some micro manipulation based sperm selection like a double density test or a hyaluronic acid like a PIXI or a sperm magnetic sorting or using IMSI to pick up the sperm. But understand that any sperm selection technologies has limitations because none of the current technologies can completely prevent you from selecting a sperm with DNA damage or aneuploidy. And that is to be understood that the pool may get better, but the sperm that you select, especially for ICSI, you have no way of knowing what is the sperm DNA fragmentation in that particular sperm. So quite a few years back, there was a trend of doing testicular sperms in patients of high sperm DNA fragmentation, because we all know that the testicular sperms are not exposed to ROS, would have less DNA damage than ejaculated sperm. However, I would like to place some caution saying that we do not want to empirically use testicular sperms. I think it's important to counsel the man, treat his obesity, diabetes, hypertension, put them on antioxidants, lifestyle changes. And despite that, if you find that there is persistently high DNA fragmentation, then I think it is important that you counsel such men to use their testicular sperm rather than their ejaculated sperm. Because we are yet to see and know whether there would be some genetic or epigenetic changes in the newborns that are born when you are using the testicular sperm. So although there are better reproductive outcomes in reports when testicular sperm was used for ICSI, then when you use sperms where there is high or severe oligospermia, I think it is very important that you try out all other ways of improving the sperm count and only then as a last resort. Some lab processing methods could be changed. So prolonged incubation, prolonged centrifugation, use of cryopreservation sperms can significantly impact the sperm DNA fragmentation. Magnetic activated self-sortings, you can use IMSI, as I said, or PIXI can be used if you don't have access to IMSI, because these are some methods where you can try and use some microfluidic devices, trying to improve your chances of getting good sperms for use. So to summarize, sperm DNA integrity is crucial for fertilization and development of healthy offsprings. Sperm DNA fragmentation results from defective maturation, abortive apoptosis, and can be induced by a number of disease states and lifestyle environmental exposures. There are multiple assays, the tunnel test being the best assay. However, most of us would use the indirect sperm techniques for DNA fragmentation. Evidence indicates that it is most beneficial in patients with unexplained or idiopathic infertility, recurrent pregnancy loss, varicoceles opting for ART, and those who have got normal semen reports but have got some comorbidities like obesity, hypertension, and diabetes. High sperm DNA fragmentation can be treated by simple methods like recurrent ejaculation, avoiding hot environments, antioxidant therapy, lifestyle modification, varicocelectomy in the selected patients, or using advanced sperm selection techniques, and as a last resort, testicular sperms for ICSI. I thank you very much for a patient hearing and very happy to answer any questions.
First of all, sir, thank you so much for such a crisp lecture. It is always great to listen to you, sir. I just want to ask one. I'm sure there are many questions from the audience. But before that, I want to ask one question. In patients who have severe oligoacinospermia, I mean, practically, we have a DFI machine in our center. So, have you ever faced problems testing that, in your center?
If
Severe
the counts are less than 1 million, it is not possible for you to do your sperm DNA fragmentation. So,
exactly.
So if they have got very severe OAT, then it is not possible for you to do their sperm DNA fragmentation. But I think it is important to examine them, see for the testicular volume, for the turgidity, rule out any varicocele, do their simple measurements of blood pressure in the clinic, do their BMI, sugars, and see if any of this needs to be treated. Put them on antioxidants and then see whether you get any improvements.
Yes, sir. Thank you so much, sir. Thank you so much.
So we have one question from audience. Either Rubin Shah sir or Amit Patki sir can answer. If somebody is giving for testosterone for loss of libido, how long can we give the testosterone? Whether it is not more than 1 month.
So
never ever. Sorry to jump.
No, go on, Rupin.
Never ever give testosterone injectable to a man who's desiring fertility. If his testosterone is low, you increase it by giving clomiphene, aromatase inhibitor, or injection HCG. If you give him testosterone, his sperm count will become 0. So never, ever, ever. There's one thing you have to remember from this symposium is never give injectable testosterone to a man who's desiring fertility.
Oral tablets, sir?
Oral tablets, there are 2 oral tablets. One is mesterolone, the other is testosterone undecanoate. Mesterolone cannot be aromatized to estradiol, therefore it does not suppress the HPT axis. So you can give mesterolone. Testosterone undecanoate capsules are relatively very mild. A WHO study done 30 years ago found that it did not suppress the HPT axis. So the oral testosterone you can give for the reason that I mentioned, but no cream, no gel, no patch, no injection.
Is it worth measuring the total testosterone before you even think of giving this, Rupin?
Giving testosterone or something else?
No, testosterone.
Never ever give. There's nothing to do.
Tablets also, because quite often they say that it is for a decreased libido, but there could be many other reasons for decreased libido.
Oh, usually low libido has nothing to do with testosterone.
Correct.
And it is
Absolutely.
really low. It's more due to the nagging wife or the bullying boss.
Okay, then one more question from the audience. Recent studies have people have started giving letrozole for male infertility. So what is there is no much studies. What is the data or how long can we give if the TE ratio is less than 1/10?
Yeah, so you already answered part of the question. There are various methods of raising testosterone intratesticular. It could be SERMs like clomiphene or tamoxifen, or aromatase inhibitors like letrozole or anastrozole, or gonadotropins like HCG. The aromatase inhibitors are specifically used over the SERMs in typically obese men, where the testosterone to estradiol ratio, testosterone expressed in nanogram per deciliter, divided by estradiol, if I remember right, it's picogram per either ml or liter. I'm forgetting right now. But typically testosterone would be over 400, estradiol would be 20, 30. So that's 400 divided by 20 is 20. But if testosterone is 300 and estradiol is 50, 300 divided by 50 is 6. So that is a patient where we'd use the aromatase inhibitor. The common mistake I see people doing is giving it every day. If you do that and check his estradiol after 4 weeks, it will be less than 5, which is too low. You don't want estradiol to go very low because even men need some estradiol. So in general, anastrozole, for example, 1 milligram, just twice a week or at the most thrice a week is more than enough, and the same for letrozole. You give it for 2 to 3 months, see if it helps. If it helps, continue, otherwise stop.
Thank you, sir. Chairpersons. Dr. Nirmal, Dr. Ritu. Dr. Shashibala was asking some question.
Sir, which is the preferred method for this DFI calculation, sir, in your center? I mean, either Pinsa sir or Petki sir.
Calculation of what?
DFI, sir.
DFI.
Which is the preferred method, your favorite method, sir?
So, I mean, I don't think many labs have access to tunnels. So it is either chromatin assay or dispersion assay. We go by the chromatin assay.
Yes, sir. Even we are doing the same.
Yeah.
Thank you, sir.
Rupin sir, if there is a hypogonadotropic hypogonadism, won't you advise testosterone for them, sir?
So hypo is very tricky. A lot of times I'm asked this question and I feel scared because true hypo should not be managed by an infertility specialist.
Yes.
It requires extensive gonadotropins with varying doses for a very long period of time. But very quickly, since you've asked for it, you could have hypogonadotropic hypogonadism from the beginning, where the person presents with delayed puberty. That is very different in its management from acquired hypo, where pituitary tumor, brain trauma, etc., damages the pituitary, and then the gonadotropins fall, because in those cases, the testosterone the testes have already developed. So in a person who has hypogonadotropic hypogonadism congenital, when he's 13, 14, the question of androgenization arises. And there you may give testosterone for androgenization, though there is an increasing trend now to use HCG rather than testosterone, because with HCG you will raise the testosterone and the testis size will increase. However, there are some young adolescents where HCG alone is not enough, and there you can give testosterone with HCG. So you're getting the changes of puberty and also trying to stimulate the testes. In an adult hypo where fertility is the issue, there's no question of giving testosterone.
So one more question, if time allows, or can
Yes.
I ask?
Yeah, go on.
Sir, I have, seen patients of ageospermia and advised them to undergo Y chromosome microdeletion till now, 33 patients, sir. And no one is having this deletion positive. So the reports are faulty, or is it, why this is happening, sir?
No, the incidence in the Indian population is only 3 to 7%. So what the lab has told you is fine. Eventually, it comes out very once in a while. But if the patient can afford it, then if you do find the A or B deletion, you're not going to do anything further.
Correct.
It's seen only very once in a while.
Yes, sir. But always the report, deletion is.
But worth getting a karyotype also done along with Y.
Yes, sir. Yes, sir. Both tests were getting done, but deletion was not at all detected in even a single patient till now.
Sir, there is a question. Pardon?
I have a practical question, day-to-day life. When patients come to us, couples come to us, and the man has a very good body, good muscle mass, and when you ask them, then they say that I do gymming and I take proteins, and the sperm count is very low in such patients. So how do we make them understand and create awareness? Because this is a very difficult and a tricky thing to make the patients understand that the proteins are not good.
It's not just the proteins. He's lying. He's taking
Correct.
testosterone. Ask him,
Steroids?
wife
Oh,
is not there.
testosterone. Okay,
Correct.
okay.
I
So I
think
got the answer.
Rupin
Yes.
is looking after one of my patients whose testosterone levels were 3000 plus.
Yeah.
Oh my God. Okay.
And it's taken us almost 9 months after Rupin's treatment for some sperm to now come up in his ejaculate.
So your clue to these patients, and this is becoming more and more common, so it's an important question, is when you see low FSH, low LH, and very high testosterone.
High testosterone.
That is a guy who's been taking injections.
So it's better to confront them than
Quietly, when
behind
the
the
wife
bush.
is not there. Otherwise, the wife will give him hell.
Yeah, of course, very carefully. Yes.
There's a question from one Dr. Markey. In obese patient, can we give letrozole empirically? If yes, what does for how long?
I don't give anything empirically. I would look at the hormone profile and then decide. For example, obese patient, FSH-LH normal, testosterone 530, estradiol 35. There's no indication for any hormonal therapy.
Correct.
So none of these hormones should be given like vitamins. Khake dekho. They have to be given if there is a specific indication.
Okay. Another question from Dr. Ipti is that how frequently is male asked to ejaculate in repeated ejaculation in raised DFI?
So as I said, if you're going to use the sample for IUI or IVF, we proactively tell them not to keep a gap of more than 2 days before they give the sample for us.
So question to you, Dr. Amit Patki. How much do you feel that microfluidics is helpful in patients to fight the DNA fragmentation?
Yeah, so as I said, you will get a good pool of sperms, but you can never swear and say that every sperm in that is one with low sperm DNA fragmentation.
Okay.
But it improves your chances. So if you are using microfluidics, now people use it even for IUIs samples, but we use it mainly for ART samples. And in cases where we know that the DNA fragmentation has been high and we have got poor outcomes in the previous cycles.
Yeah, the embryos are definitely better that we have seen.
Correct.
Good evening, sir. This is Dr. Indira, sir. Dr. Amit, sir. Good evening. We recently met in ISAR, Patna.
Yes. How are you?
I'm good, sir. One question I wanted to ask, sir. Any role of clomiphene 25 milligram as seen in my practice that some are prescribed clomiphene, some male factor in patients, as well as HCG injections. But I haven't seen much improvement, but they have been prescribed. So any role?
I think Dr. Rupin has answered that question on doing the testosterone estrogen ratios and only as an anti-estrogenic. Now, if you have to increase the testosterone, it has to be in the micro environment. So HCG injections are given in association with gonadotrophins in these hypo patients, but you have to counsel them that they may have to take them for almost 90 days. So sometimes it's a combination of twice weekly HCG with HMG. I think Rupin can explain better because we refer such patients to andrologists. But it is an expensive treatment. That is something they have to understand.
So I think we have to divide this into two groups of patients. Those who are truly hypo, which means FSH, LH, testosterone all well below normal. Again, I repeat, you should not be treating those patients.
Correct.
Then we are talking of the eugonadotropic patients whose FSH, LH are not low. Either they are normal, high normal, or above normal. So the question before you ask, should we give clomiphene, the question should be, which patients need hormonal manipulation? You can't give again clomiphene empirically. Who needs hormonal manipulation? There is no strict rule about it, but in general, if the total testosterone level is less than 400 nanogram per deciliter, that means that there is scope for stimulating this testes. So if his testosterone is over 400, you don't give anything, neither clomiphene nor HCG, though some people use 600 as a cutoff. There's a large paper widely quoted by Craig Niederberger, where 600 was their targeted goal. But otherwise, 400, 450 seems reasonable. So if testosterone is already normal, then even if FSH, LH are low normal, you don't give treatment because that testis is adequately stimulated. If testosterone is below 400 and you feel, yes, we want to stimulate this testes, then you look at FSH, LH. If FSH, LH are already above normal, then giving anything will not help because already this testis is being stimulated adequately, but is not making enough testosterone because of testicular failure. If, however, FSH, LH are normal or low normal, then you have the option of trying to stimulate this testes, in which case you can give clomiphene. Clomiphene 25 milligrams daily is a good dose. After 3 to 4 weeks, I check FSH, LH, testosterone again to see if they've all gone up adequately. In the majority of cases, 25 milligram daily is enough, but in some cases it isn't, and then you can increase it to 50 milligrams or add HCG to such patients. So you have to keep on fine-tuning it.
Okay, so thank you so much.
Sir, about the clomiphene, sorry to ask this. Maybe I'm asking a very stupid question, but previously, like we used to hear that clomiphene you have to take for 25 days, then take a break of 5 days. I mean, is it still, are we still doing the same thing, sir?
So that was started by Paulson almost 40 years ago in his first papers on clomiphene, because clomiphene has an extended half-life. It tends to accumulate. That's why some people even use a dose of 50 milligrams alternate days or 100 milligrams twice a week. So it was on that basis that he recommended the 5-day gap. But many people don't follow it. I don't bother to. It's an option if you'd like to. In the olden days, in fact, it was sold in packets of 25, but nowadays it'll be sold in packets of 10 or 30. So it's optional either way. But that was the rationale for the 5-day gap.
Ripon sir, one question to you. So should we centrifuge every sample of azoospermia?
Absolutely. You cannot diagnose azoospermia if a centrifuged pellet has not been examined and an extended sperm search has not been done. The diagnosis and the future management will change dramatically.
Okay, one more question. Total asthenospermia, how to proceed? Count is normal.
That's for Amit or me?
For you.
Give that to Amit.
For Rupin.
Because it's a difficult question. So let Amit answer it.
For Rupin Shah.
Okay, so go ahead, Amit.
No, what is the question? I didn't listen.
Okay, the question was astheno, how do you manage? So astheno, again, as I pointed out in my talk, differentiate between oligoastheno versus isolated astheno. And an isolated astheno, mild to moderate astheno or very severe astheno. Severe astheno will not respond to any treatment. They need IVFXC. Moderate astheno, 30% motility instead of 40, slow progressive instead of rapid progressive. Those are the ones where you may look for infection. If seen, give antibiotics. If you want, you may test for antibodies, but that's controversial. And that is where you may want to give some nutraceuticals with coenzyme Q10 and levocarnitine and all those things for a couple of months, and some of them will improve.
Yeah, I've had 2 patients which had total zero motility with good count, and two of them were diagnosed to have genetic defects of ciliary, and they also on examination gave history of chronic cough, and one of them actually had even a pneumonia, recurrent pneumonia. So you occasionally see such patients. In my career, I've seen only two such patients where zero motility, but we went ahead and we did their genetic testing and we found that they had this problem. So only two of them.
So the next test is genetic test, right? This is what I wanted to ask.
Yeah.
Okay. Thank you, sir.
Okay. What did the genetic test reveal?
So there was a gene mutation for ciliary. So that is why he also had recurrent consolidation and bronchiectasis in his lung. So it was picked up by my junior who said that he constantly takes nebulization. He's constantly on antibiotics for his recurrent cough. And that got me thinking that maybe we should get him tested for this.
So there are two options. You could do the genetic testing, and there's a whole list of genetic defects associated, or you can do electron microscopy, which will then reveal the actual structural defect.
The ciliary defect, correct.
Which could either be a defect in the dynein arms, which is the classic cartilaginous syndrome, or there are defects in the microtubular arrangement, which is another variety. And many of these people also have disordered genetic material, so the prognosis is not so good. Absolutely. But before we do that, as I mentioned in my talk, you need to differentiate between live immotile, which is what Amit's two cases would fall into, versus dead immotile. If they're dead immotile, that's necrosospermia. Their electron microscopy and genetics are not required. So that distinction is important before you jump to what test to do.
If I can add here, with regards to 100% immotile sperm, I think, like was said, it's basically between whether it is live or it's a live sleeping sperm or a dead sperm. So you have procedures in your IVF lab that are available to actually pick up those immotile live sperms, like your horse test. Today we have sperm stimulants available like theophylline, pentoxifylline that is available, where you can actually go and pick up those. Once you add that to your semen sample, the tail starts twitching. So you can actually select those sperms. There's something called as a sperm tail flexibility test, where you actually know and select these sperms according to the flexibility of the tail. You know that sperms are live. So if the second phase, once you evaluate, ultimately we want to know how to treat them also. So the next phase is to actually select the live from the motile ones. And these are the different processes that are used.
I think this point that Parasuram made was very important, because often I see patients where they've done an IVF cycle somewhere and the embryologist note says dead sperm seen, and I quiver and shiver, because very often what they've written as dead sperm are actually live immotile sperm. And then the techniques which were just mentioned, if they had been done, they would have been able to proceed with the IVF.
Sir, one last question. In books, we see about the ejaculatory duct objection, TRP resection of and opening up. But in the practice, how many cases have you seen, or how do you properly diagnose it, whether to see the fructose in all the cases, or how do you differentiate those cases?
How many cases? We are doing one tomorrow. And how do you diagnose? See, they're not very common. And the classic picture will be low volume azoospermia, fructose absent. However, ejaculatory duct obstructions can sometimes be partial. So if you have low volume but some sperm, that could still be ejaculatory duct obstruction. The diagnosis is primarily based on a good transrectal ultrasound, or even more accurate MRI of the pelvis. The transrectal ultrasound is very subjective. We've seen all kinds of wrong reports. MRI also has to be done by someone who's good. So if you suspect that, this is where you need a good uroandrologist. Don't try and mess around with it.
Any other questions?
As clinicians, should we refer when should we refer our patients to a urologist? if it is a high DFI, Dr. Amit, should we refer? I mean, at all, or we should treat them? I mean, we are treating. Do we refer all our patients to a urologist for examination in a high DFI patient?
No, I don't. As I said, I look for any comorbidities. I see whether I can treat them. If I find that there is something more than just sperm DNA fragmentation, like abnormal semen parameters, then obviously you would send them to a uro-andrologist.
Okay, thank you, sir. Thank you so much.
Okay, thank you. Thank you, Rubin Shah sir and Amit Patki sir. Dr. Anu, we will go ahead with the next session.
Thank you.
Thank you.
Thank you, Amit sir. It was a wonderful talk and a very vibrant discussion. So we'll move to our much awaited panel discussion, case scenarios in male infertility. And our moderator is Dr. Kunju Moinuddin. Please. Sir's CV, please. Dr. Kunju Moinuddin's CVs. Yes. Sir has 27 years of experience in the field of reproductive medicine and gynec endoscopic surgery. And Sir is President, Kerala Foundation of Obs and Gynae, Medical Director of Birla Fertility, ARMC. Welcome, sir. And Sir will invite this panelist.
Yeah, you can introduce, please.
Okay, so our first panelist, Dr. Usha Yadav, a great friend of mine. She's IVF consultant at Sri Fertility Center, Varanasi, Secretary VMS. Next panelist is Dr. Indra Prasad. I met her in Patna, ISAR Patna only. She's additional professor, Department of Obstetrics and Gynecology, AIMS Patna. And she has done diploma in gynecological endoscopy, and she has done fellowship in IVF and ART. Next panelist is Dr. Radha Agrawal. She's gold medalist, senior consultant, Sushrut Hospital and Maternity Center, director of Sushrut IVF Center. Welcome, Dr. Anuradha. Dr. Shashi Bala. She is director of Avita IVF Patna, and her area of interest is infertility, gynae endoscopy, cosmetic gynecology, and high-risk pregnancy. Welcome, Dr. Shashi Bala. Dr. Reggie Mohan. He has done short-term fellowship in reproductive medicine from University of Ghent, Belgium. Additional professor in the Department of Reproductive Medicine and Surgery. Welcome, Dr. Reggie. Next, Dr. Parasuram Gopinath. He is medical director, CBAR Cochin, a unit of Edapal Hospitals Private Limited, Kochi. Welcome, Dr. Parsu. Over to you, sir.
Yeah, you can stop sharing. Yeah. Hope it's visible.
Yes, sir. Visible, audible.
Yeah. So, good evening, everyone. So it's we are going to discuss something about different cases in male infertility. At the outset, I thank Dr. Amit Patki and Dr. Fessy Lewis for giving me this opportunity to moderate this panel. And I'm really sorry to the panelists that I couldn't get ready this panel things well in ahead and give to you. But I'm sure all are the experts, Dr. Usha, Dr. Indira, Dr. Anuradha, Dr. Shashibala, Dr. Reggie, and Dr. Parshuram. All are stalwarts in fertility treatments. Hope we will be able to sail through with a good discussion. And many of the points in male infertility have already been covered during the discussion in the previous two talks. But we will look at these things in a little bit different way. So we move on to the first case. And my request to all the panelists, please, only the panelists who I am... Hello? Only the panelist to whom I'm asking, please answer. If anybody else wants to answer, please raise your hand. So we will give them the opportunity to answer. So the first case, The first case, 38-year-old male presents with severe oligospermia, that is sperm count less than 1 million, and the karyotyping was done, which was normal. And his hormonal profile shows normal testosterone, but elevated FSH levels. He has a history of childhood mumps, which led to orchitis. The couple has had 3 failed ICSI cycles with poor embryo quality. The male partner refuses sperm donation. Hope the case is very simple for all of you to handle. So we'll have these points for discussion from the panelists. Role of genetic testing, options for managing severe oligospermia. You all heard about in the past 2 lectures and will be easy to handle that. The potential benefit of testicular sperm extraction versus ejaculated sperm. Use of advanced sperm selection techniques. Whether antioxidant therapy could improve outcomes in subsequent cycles. So we will look at the controversies with regard to all these points. So let me look at Dr. Usha, who can handle these questions. The role of genetic testing.
It's very obvious, as you said, he suffered from mumps in childhood. So very likely he had orchitis. And this is the time perhaps his testis is mostly damaged. So I don't think there is much to gain from doing genetic testing. Rather, testicular biopsies will be a better choice for me. And if some sperms are retrievable there, we can offer her TSA or micro TSA.
Yeah. So in your practice, if it is a case of severe oligospermia, leave alone the history of mumps, will you be doing the Y chromosome microdeletion testing for all patients with severe oligospermia? What is your routine practice?
No, sir. This is, I think, rationally should not be given. We don't do it.
No. I'm not asking about this particular patient in general.
Otherwise. Yeah, in severe oligospermia, we do advise.
Yeah. So, so what is the advantage of doing it? Just see, even otherwise, in severe oligospermia, if the report is coming as Y chromosome microdeletion testing, deletion is present or not present, what is it going to give us rather than having a report and alerting the patient that your offspring will have the same thing if it is going to be a boy? Other than that, does it give any clinical relevance?
No, sir, but we can counsel in a better way. And we have to counsel very thoroughly. And we should not rather encourage them to exceed with their own sperm, because they're going to transmit it to their offspring and their male child is going to suffer. Similarly, for cystic fibrosis, as sir was saying, this gene deletion also, this is also transmitted to females. So before that, we should do this same genetic testing for female also. If she is also suffering, they are bound to transmit this. So this helps us to give her better counseling.
Yeah. So we will look at others for their opinion. Dr. Parshuram, will you do Y chromosome microdeletion in this particular case or in general? What is your take on that?
Generally,
in your practice?
Generally, in these patients, we generally end up doing your routine karyotyping. Not really. We basically end up doing Y chromosome microdeletion primarily in patients with azoospermia, especially non-obstructive azoospermia, where we want to predict the possibility of getting sperm when you're doing a sperm retrieval.
Yes.
We know that if it's an A and B is absent, then you will not get a sperm. C, there's a possibility of getting sperm. Now, in this particular patient, yes, you can do it only for a counseling point of view, where we can counsel a patient to say that, okay, there's a possibility that, yes, if you have a male child, the child is also going to have Y chromosome microdeletion. But then as a doctor's perspective, it's always important for us to put forward that option, because you have to tell them that this is a possibility, and probably you don't know by the time the child grows up, that point of time, there might be treatment available for Y chromosome microdeletion. So I would always say that always give them an option.
Yeah.
These are the possibilities. Do the treatment, and also they see it should be a informed decision that each patient takes. So I think that is
rather we can say it's a sharing decision. We can just inform that these are the plus minuses. But like you well said, the treatment modalities might be quite different by the time the child grows up, isn't it? So the identifies genetic causes and guides treatment decisions. Like Parshuram has told, in general, microdeletion type AZFABC helps determine the likelihood of sperm retrieval success in TCA procedures, because very often this severe oligostenospermia, very often in this severe odds, sometimes we may go for testicular sperm retrieval in cases of previous ICSI failures with poor embryo quality. In such cases, with AFC, microdeletions having the highest success rate, and informs patient counseling and avoids unnecessary interventions, can prevent repeated unsuccessful ART attempts. Like Dr. Usha mentioned, we can even counsel, even though this particular patient, the couple were not willing for the donor procedures. So the conclusion, microdeletion of AZFC region of on Y chromosome impaired fertilization and pregnancy rate of patients undergoing ICSI treatment. And what are the options for managing severe oligospermia? Actually, you need to summarize all the points what you heard. Shall I hear from Dr. Indira Prasad? Dr. Indira? Dr. Anuradha Agarwal? Are you there?
Yeah, sir.
Yeah, Dr. Indira is speaking. Dr. Indira, please.
Yeah. In case of severe oligospermia, actually there can be various causes. We have to first of all find out the causes for severe oligospermia, and then we go for management. So as if we have done the Y microdeletions is already discussed, then we will go for, we have to see which part of the Y chromosome is deleted, actually, proximal, middle or distal, and it causes different types of oligospermia. Then we can go for, accordingly, we have to treat, as madam also said that it's better to go for a genetic counseling, and if they can prefer for a donor sperm or go for IVF with PGD. So that is about the genetic causes. And others, if we initially can go for antioxidant treatment like vitamin C, E, D, that will reduce. Am I audible?
Yeah.
Hello. Yeah.
Yeah, please.
Then on history, these days, what I find occupational hazards are also there. So we have to take out time for to talk to the couple, because many times as infertility specialists, especially in our government setup, we are so much worked up, and in heavy OPDs we are dealing with the ladies. We don't have enough time and space also to sit with the male partners and discuss the history in detail. That what is their occupation, how much stress is there, and whatever the quartal frequency or any problem. So that type of counseling is also important. And so after that, even though psychological aspect can help us treat some amount of oligospermia there. Then, of course, so lifestyle modification and basic, starting from the medical management, from the antioxidants and some exercise, and if those are details of sedentary lifestyle is there. So metabolic syndromes with diabetes, hypothyroidism, all these things have to be looked into. Deranged lipid profiles. I have currently a thesis, DM thesis under physiology. I'm a co-guide there. So they are doing the yoga therapy for the male factors. So trying to see, randomizing the patients, and then let's see what comes out. Then of course,
thank you, Dr. Indira.
then we can go for
we'll move on to the others also. So Dr. Reggie Mohan, are you there?
Yes, sir.
Yeah, what is your critical opinion regarding the advanced sperm selection methods in cases of severe oligospermia, particularly in this patient, whether you go for in your government setups, or what is your general opinion with regard to the guidelines?
If you have the option of a sperm sorter like Max or Pixie. Definitely, we have our embryologist is using a Pixie dish if it is available. Then you can go for even for a IMSI also if your embryologist is well versed with an IMSI and you have an IMSI machine, and so you can select the sperms more clearly, and at least the morphology part you can be sure of that which sperm you are injecting. So if it is available, the sperm selection techniques, if it is available, definitely I'll go for that, since it is a recurrent failure.
Yeah, Reggie, if I say that all these things, Pixie, IMSI, Max, all those things, even though it may increase the fertilization enhancement or the more fertilization rate, it is not going to cause the live birth rate increase. Will you contradict it?
Sir, since this is a case of recurrent failures, so you have, I think, mentioned in the history that there are 3 failures. So they'll be desperate to do something. So if you have something, you can offer it. That's my take.
Okay, but most of the guidelines do not support the advanced sperm selection techniques with regard to the cumulative live birth rate as well. And testicular sperm extraction is another option, like we mentioned, and it should be micro-TSA and ICSI with a genetic testing, that is PGT, because it is already recurrent failure. And donor sperm is, of course, like you all said, has to be counseled. So can antioxidant therapy improve ICSI outcomes in subsequent cycles? My question is very clear. You are going to try this patient because patient wants one more cycle of ICSI before taking that particular patient for ICSI again. Will you try antioxidant therapy? This patient might have already had tons of antioxidants, various options, various brand names, but when we are going to take up this patient for the next cycle of ICSI, will you recommend antioxidant therapy? If what are the drugs you suggest, for how long, and when will you take this patient for ICSI? Dr. Anuradha?
Sir, as the patient has had 3 recurrent implantation failures, I am very sure that the patient would have had all types of treatments. By the time the patient has had 3 cycles, I'm very sure they would have had everything under the sun. They would have taken everything. But still, if the patient wants to go ahead with it, then I would say that because it is a non-invasive technique, they can always opt for it. I mean, they can always give it a trial. But as far as
No. Here the patient is telling, Dr. Anuradha, you decide. It is not, they don't have any option because they want a baby only. They are coming to you for the next ICSI, the 4th ICSI, and they are telling, Dr. Anuradha, you do whatever you want. So will you prescribe?
I would counsel the patient first, because in all these patients, I would tell him that they have already had a lot of these drugs earlier also. Still, if they want to try anything, antioxidants can be given. But after 3 months, we would like to sort of repeat the semen parameters to see if anything significant has happened, especially for a sperm count as low as 1 million.
No, Anuradha, here question is very clear. If they don't want that situation, that option is not available. Whether will you give or you won't give?
So I don't think that antioxidant therapy can make any magical changes in a person with a count of 1 million. I don't think.
Yeah, but in this particular patient, there can be oxidative stress. To get a better sperm with low DNA fragmentation, of course, there are things which you can try by the time patient is waiting, and at least that should be given for 3 months. And studies on sperm DNA fragmentation indicate that antioxidant therapy can lower the sperm DNA fragmentation, which can, again, because all the previous things were showing the poor quality embryos. So we should do all possible ways and means to improve the embryo quality. But we have to keep in mind that the studies on these antioxidants, we will go little bit detail on that part in the coming case also, but the studies are conflicting in this particular thing. So antioxidants in culture media improve ICSI fertilization rate, results from a randomized control trial. So do anybody have this experience? I think Dr. Parshuram might be involved in embryology also. Is it so now, or it was past? Dr. Parshu?
A little past, little now.
Yeah, a little past. So
Yes.
this study, single center prospective randomized control trial, superiority study comparing G series media with or without the addition of A3. A3 means that three antioxidants. January 2019 to 21. And the summary answer for that randomized control trial is antioxidants in the media that increase the ICSI fertilization rate. Consequently, the number of blastocysts utilized, but the clinical pregnancy rate from fresh transfers was not affected.
Sir,
So yeah, please. You want to add something?
The whole idea is that, see, if at all why are we giving antioxidants? We are giving antioxidants to probably improve the sperm quality that has been generated. Whatever is already damaged is damaged. So the further sperms that are coming, so if at all we are giving antioxidants, we should give them some time so that the sperms that are coming.
Yeah, that's why I mentioned 3 months. 3 months.
So, but in here, the situation, when you're actually a damaged sperm is there and you're putting antioxidants, that I don't know whether antioxidant will go and repair the damaged sperm. I don't know. So I don't know if this can be actually accepted when you're looking at this particular scenario.
Yeah, but this why I quoted this study, because the study design is very good. So it is randomized, and it is randomized even before egg collection. So that's why, and the number of patients they studied also was a very good number. 1,482 patients were randomized. So the study reports we cannot.
Antioxidant has affected the oocyte quality.
Yeah, might be. No, it's actually in the cultural medium, so it might have affected. But in that inclusion-exclusion criteria, they have included only the patients with a good oocyte quality at the time of retrieval, and the others were excluded to avoid the bias. Anyway, because that study design was good, I just put it across. And we will move on to the next case scenario. We will discuss with Dr. Shashi Bala with your expert opinions on this particular case. 34-year-old male with grade 3 varicocele and non-obstructive azoospermia is referred for fertility treatment to Dr. Shashi. Hormone levels indicate borderline low testosterone and high FSH. Genetic testing is negative for microdeletion, but shows heterozygous, read it carefully, but shows heterozygous CFTR gene mutation. The couple is considering ICSI with Dr. Shashi Bala. Okay. So the points for discussion: will you repair varicocele before IVF or ICSI? Remember that this is a grade 3 varicocele with azoospermia, and role of testicular biopsy and the possibility of finding sperm in this particular patient, because it's a case of low testosterone with high FSH and risk of transmitting CFTR. No, let me complete this one. I'll come to you. The risk of transmitting CFTR mutations to offspring and the need for pre-implantation genetic testing, alternative options if testicular sperm retrieval is unsuccessful, and how to counsel the couple about fertility. Why I'm showing these points of discussion so that others can be ready with the coming up questions. So should varicocele repair be considered prior to IVF or ICSI? Dr. Shashi, the patient has come to you.
Yes, sir, because it's a grade 3 varicocele, it is better to go for varicocelectomy before IVF or ICSI, sir.
So what are you going to gain? She is already a patient of azoospermia. High FSH.
So maybe after repair, maybe we get some sperms.
But
in her
varicocele surgery can worsen the situation also, because the patient is already on the brim. You may push him down to the sea.
In that case, we have to counsel the patient in both ways, sir, and he can decide accordingly. And if he's not ready for varicocelectomy, we can counsel him for microtesting. And before that, we have to test wife also for CFTR gene mutation, and accordingly, we can counsel.
Wife is a superwoman, perfect. All hormones, perfect. Ovarian reserve, so good. No female factors.
Then we can proceed for microtesting, sir, with ICSI.
Yeah. So I'll ask to the person who might be doing a lot of varicocele repair. Dr. Raji, you do a lot of varicocele repairs, I heard.
Sir,
Dr. Raji?
Yeah, first and foremost thing is I would like to.
No. First question: do you do varicocele repairs yourself?
Not myself, urologist.
Urologist. Okay. Please.
So first and foremost thing is I would like to store the sperm before undergoing. Suppose if I counsel the patient and if they agree
From where you are going to store the sperm?
No, if there is, it's a case of azoospermia. Sorry.
Yeah. It is 000. You have to store something else.
So, varicocele repair in azoospermia is a controversial topic. So, some papers have shown that the chance of the retrieving a good normal sperms is high with after a varicocele repair. Again, depends upon the testicular volume. Again, this depends upon the FSH level and the FSH and the testicular volume. So if good testicular volume and if it is just normal FSH or on the lower side, you can give the option of doing a varicocelectomy. You have to counsel. Counseling is the key thing, and you may get a better sperm. Not always, better sperm.
I agree with Dr. Shashibala, who has told that it can improve the better sperms. I agree with you also. But the evidence is really conflicting on ART outcomes. While some research supports varicocele repair for better ART cells, meta-analysis show mixed outcomes, highlighting the need for individualized treatment decisions. Specifically, in this patient with high FSH, we have to be very careful in going ahead with varicocele repair. And the role of testicular biopsy and the possibility of finding sperm. Who will answer, Dr. Usha? In this particular patient, when you do a testicular biopsy, what are the possibilities of getting sperm? Or can you do something to increase the possibility?
First, I think she's, I think in this case needs HCG injection first. And then we see the effect
You mentioned HCG injection. What is your protocol in giving HCG injection in your clinic?
We give twice.
How much you give? Hello? Not audible.
And that ISAR connection, it is stuck.
Yeah, we will move on to Dr. Indira. Would you like to take up this question, the role of testicular biopsy and the possibility of finding sperm in this particular patient? And will you do something? Dr. Usha has already mentioned about HCG. Dr. Indira, are you there? I think Dr. Fesi, can you take up that question?
2000 IU. 2000 IU HCG.
IU. Yeah. Twice weekly.
Yeah.
Yeah. How many weeks you give?
For 6 to 8 weeks. And then we see the testosterone levels. If it rises, that means we are getting some response. And then might be it is possible some spermatogenesis starts. And then that is the time for testicular biopsy.
So in this particular patient, the FSH is already high. Will these hormones work? Do you think?
Sorry, if I can add.
Yeah, please, pursue, please.
See, gently now, this is a patient with.
First, what will be the protocol? Pursue. What will be the protocol if the patient is coming to you? Before testicular biopsy, will you do something? Or what is the possibility of finding sperm?
I don't see there is a role of a testicular biopsy. The only option is that sperm retrieval and use. So
yeah. Basically, sperm retrieval. That's what actually meant. That's what actually meant.
So the only option is probably to go ahead with either if the FSH level is not very high, probably do a trial TISA and see if there is sperm retrieval available, but do it only in a place where you can actually cryopreserve the sperms also. But if you feel the FSH is higher, then probably the only option would be to stimulate the patient once the eggs are ready, then only go ahead with the micro TISA. But this all has to be done after extensive counseling and telling the possibility of a cancellation of the cycle if you don't get a sperm, or the possibility of using a donor sperm. So because what happens when the FSH is very high, actually, like what you have told, the possibility of getting fine foci of sperm is only there. So if you get those sperms also, the only option is whether if we freeze those sperms, how do we retrieve them back? There are devices available today, but then again, that is not a very common thing that is used. Like there is something called the sperm VD. There is something called a sperm VD and devices like that.
Yeah. So here, like you said, it is very correct. We have to do micro-TSA. So the first micro-TSA is the best one to retrieve the sperms. Am I right, Parshu? 30 to 50%, depending on the patient profile. Yeah. And there are factors like the histological patterns. So that also is very important. If the patient already might have had some biopsies with some testicular biopsy reports coming from outside, and the retrieval, the possibility, it will help you to counsel the patient when you are going to do the second micro-TSA. So hypospermatogenesis patients can have better chance, like we all know, rather than the Sertoli cell only syndrome. Like Dr. Usha mentioned, so the chance of giving these hormonal therapies, so that is very important. So the secondary hypogonadism or situations like where FSH is not very high, or even FSH is normal, it can work better along with antioxidant therapy, which we have mentioned earlier. So gonadotropin treatment in testicular, these patients before testicular sperm extraction in non-obstructive azoospermia, single center cohort study. So the methods, the retrospective cohort study included almost 500 plus non-obstructive azoospermia men who underwent micro-TSA with or without 3-month preoperative HCG or HCG plus HMG between these 3 years period, and the primary outcome was sperm retrieval rate of micro-TSA. Preoperative gonadotropin therapy seems to have a role in improving sperm recovery rate in non-obstructive azoospermia patients with hypergonadotropic hypogonadism. Okay, so here they clearly mentioned about the efficacy of this one, even if the FSH is high. And we found that gonadotropin therapy had no effect on ICSI clinical outcomes and live birth rate. And does hormonal therapy improve sperm retrieval rates in men with non-obstructive azoospermia? It's a systematic review and meta-analysis. You look at it, it's a low-quality evidence, moderate or severe risk of bias. And hormone therapy overall appears to increase sperm recovery rate, but only in men with non-obstructive azoospermia and normal gonadotropin status. So it is all better to go with analysis and things like provided. And many studies do not report adverse events. We cannot advocate the use of hormone therapy in men with non-obstructive azoospermia until further high-powered RCTs are performed. So next, who will take up this question? Dr. Anuradha, risk of transmitting CF, because already it was mentioned in the history. Patient is a case of heterozygous FTR mutation, and risk of transmitting this mutation and the need for PGT in this particular patient. What will be your approach? Dr. Anuradha, are you there?
Yeah.
Yes.
So the patient has to be counseled that the patient has CFTR mutations and therefore this is transmissible. So in these cases, it has an autosomal recessive inheritance. So in both these things, not only the male partner, the female partner also has to be counseled.
Yes, perfect. So the female also had to be not only counseled, to be evaluated.
Yeah, and in these cases, a pre-implantation genetic testing is also recommended.
Must.
Sir,
so here, the PGT-M has to be done. That is recommended to screen embryos for CFTR mutations before implantation. So 2 important points. Anyway, before, as a part of PGT workup, you have to do the female partner evaluation as well. And that is very important point. And PGT-M can be counseled and recommended to the patient.
Sir, and sir,
and yeah, please.
Basically, that CFTR, this is like we were discussing about non-obstructive azoospermia. This is primarily CFTR gene mutation is primarily in the CBAVDs. So your
yeah, that's why first I mentioned. So, but heterozygous varieties can be seen in other types of azoospermia as well.
Okay.
So that's why it is mentioned specifically as heterozygous. But usually CFTR mutations, as you pointed out, it is commonly seen CBAVD, associated with CBAVD. So alternative options if testicular sperm retrieval is unsuccessful. So Reggie, this patient actually you did sperm means microtissa. Okay, but the patient, the female, was not ready to get stimulated. So you did just a microtissa. Your plan was to get the sperm and freeze it. You didn't get any sperm. What will be your next step?
In microtissa, no sperms obtained means, again, it's unlikely to, if the patient is willing for a donor sperm, definitely you can go for a donor sperm. Otherwise, you can give the option of freezing. No, patient is not stimulated. No? So
Not stimulated.
Not stimulated.
Because they don't want to spend money without knowing the sperm is there. She is not ready to take injections.
Okay. So
that's why she left Dr. Parshuram's clinic and came to Trivandrum.
So both testes
Parshuram told we will not touch you without you getting the stimulated.
Both testes
wants to spend all the injections.
Both testes were this thing microtissa was done on both testes and nothing was obtained.
Yeah, only 2 testes, both were there.
And almost all it was started properly and sampled from all the areas. Definitely, you have to go for a histopathology also. You send, whenever you're doing a microtissa or a tessa, this thing, you can send for a histopathology for just for counseling purposes also. Suppose if it is a hypospermatogenesis and all, then again, there's a chance of getting sperms. But again, other things like even maturation arrest also, there is a chance of getting getting a sperm. Sertoli-Oley syndrome, I think, less chance of getting sperms.
Yeah, so I'll look at Dr. Shashi Bala. This patient had done testicular microtissa by Dr. Reggie. Reggie told to go for donor programs. He was not willing. Somebody in the Instagram told about Dr. Shashi Bala. They came to you. What will you suggest?
Sir, I would like to see his histopathology report, sir, if it is available. Because if it is maturation arrest, we can give him gonadotropins and we can repeat microtissa again. After proper pre-procedure counseling, that we have 20-30% chances of getting sperm in the repeat microtissa.
Yeah, because this patient is already FSH is high. Will you try gonadotropins again after this initial microtissa? Because he already received. Reggie has already given it for 12 weeks, then did microtissa, no sperms.
Then, of course, no, sir. I will advise him to go for either adoption or.
Yeah. But otherwise, you want to give injections and try microtissa.
Yes, sir. If it is maturation arrest, then I would like to try with gonadotropin, sir.
Yeah. So maturation. So it was maturation arrest
especially
only.
Early maturation arrest. If it is early maturation arrest,
and what gonadotropins and what dosage? How many weeks you give?
So generally, I start with 2000 HCG twice weekly, along with 75 international unit of HMG twice weekly again, with some good antioxidants.
So you will increase the dosage. That means to start with.
After 2-3 months, sir. If the repeat hormonal profile is supportive or satisfactory, then if the hormonal profile is satisfactory, we will continue with the same dose. Otherwise,
as such in this patient, hormonal reports will not be supportive because it's already high FSH. You are giving empirically.
It was only FSH high, I think.
Yeah. So this patient, you did microtissa again, no sperms detected. And to whom I will ask again, Dr. Anuradha, this patient came to you. One microtissa done from Reggie, one microtissa done from Dr. Shashi. Dr. Anuradha, what would you like to do?
So Dr. Anuradha has unfortunately left because of some medical emergency, sir.
Yeah. This Anuradha's question, I think Fesi can handle. That patient has come back to Kerala and met Dr. Fesi. Fesi, what will you do?
I think if a microTISA is done once, I think there is no point
Twice.
in
Already twice.
twice. I think I don't attempt to go for encourage to go for a microTISA again. And usually I advise microTISA only if possible to combine with I mean after stimulation during pickup, because even
No,
if
so we cannot we cannot be so strict about it if the patient doesn't want to do donor, because you will be pushing them for donor, no?
yes, that we will give the option. If you don't get
Patient is not ready for donor. So will you reject doing microTISA for that particular patient?
We will do the microTISA along with that pickup only. Otherwise, we tell that even
No. I am telling this particular patient doesn't want to have any donor programs. So it won't look nice to stimulate the wife, no?
No. They have to take the risk along that, because even if you get the sperm by microTISA, we cannot. There won't be enough to freeze that. We have to use that immediately. So there is no point in doing it.
Parashu has already mentioned about some vitrification device or something, no? That even one sperm can freeze.
That is theoretically, but practically how far it is getting result, I don't know. I don't have much practical experience.
So we will come back to the point. So 2 microTISAs were done, both were negative. In between hormonal therapies were done. You will not repeat microTISA. That's the take-home message from you. Am I right?
Yes.
Yes.
Yeah. So this topic is open to everyone. How many times we can do microTISA for a patient? Because that is one thing which I want to give the message to the audience.
Sir,
so anybody can answer.
If it is done by a qualified person who has an expertise in microTISA and done in a lab where they're properly examined, taken time, checked, I don't think there is a role of a second microTISA.
Correct.
Okay.
And especially if the size of the testis is small.
Yeah, this is one study which has appeared in 2021. The efficacy of the second microTISA sperm extraction after failed first one in men with non-obstructive azoospermia. They concluded that on the basis of the results, 18.4% of men with the failed first microTISA had a probability of sperm retrieval with the second microTISA, and patients with successful sperm recovery had smaller testicular volume than those with a failed second attempt. Severe testicular atrophy was not a contraindication for the second microTISA in such patients.
But as Parsi told, that depends on the person who did the microTISA, who is experienced in that, and how much time it has taken to see the tubules under magnification. Specifically, this microTISA is done.
But of course, these studies where it was done, they might have done properly only. An outcome of first and repeated testicular sperm extraction and ICSI in patients with non-obstructive azoospermia. Intervals recommended is 3 to 6 months between TCA attempts, and success rate of sperm recovery after failed TCA was 46.5% with a salvage microTISA. And testicular tissue, the amount of testicular tissue in each patient is limited and does not regenerate after biopsy. So that is the most important point, unlessly traumatizing. So to all the audience, the reason for doing microTISA with a stimulated female partner is to avoid trauma and creating antibodies, so that in the second attempt will not be that much successful. So repetitive trauma to the testicles can cause irreparable damage. And conclusion, this study has concluded that the outcome of repeated TCA cycles up to the 4th trial justifies the procedure. Here, TCA means in all the, because I just written down from that article, here TCA means microTISA. And that is in general, we'll skip that. And we'll move on. Do we have time, Fesi?
Yes, I think we have got one more case we can discuss.
Yeah. So here it is a 40-year-old male with a retrograde ejaculation due to long-standing diabetes present with infertility. And multiple attempts to retrieve sperm from urine post-ejaculation have been unsuccessful despite alkalinizing the urine. The couple has failed multiple IUI cycles, now considering IVF. So the discussion points: optimal management strategies for retrograde ejaculation, utility of electroejaculation if anyone has experience, or versus the surgical sperm retrieval, how to optimize the urine sample processing for sperm retrieval, and whether IUI is feasible with retrograde ejaculation, or should we recommend IVF ICSI straight away in case of retrograde ejaculation. So what are the optimal management strategies for retrograde ejaculation in diabetic patients in a stepwise manner, not to take too much of thing. So who will take it up can come forward and answer this. I think you heard all the points in the previous discussion by Dr. Pinsha. Dr. Usha, you want to answer that?
Yeah, actually my net had just gone. I could not see the entire case.
Yeah, it's a, see, you can just tell us what are the optimal management options for retrograde ejaculation in diabetic patients. What all things you suggest, or you straight away refer to urologist?
No, we can collect the retrograde ejaculation sample after proper giving after proper alkalizer, and then thorough centrifugation. We can some pumps and enough for IUI. And if it is very less, very low in number, then of course she should be given option of ICSI.
Yeah. So here we can even treat medical therapy, the pseudo ephedrine or beta ephedrine or imipramine, and surgical techniques, collagen injections to the bladder, neck, and testicular sperm extraction. And bladder alkaline, it is not the same thing, simultaneous procedure. I just mentioned about two procedures, bladder neck injections or testicular sperm extraction. Bladder alkalinization, like Dr. Usha mentioned, properly alkalinizing the urine with sodium bicarbonate before ejaculation. And sperm retrieval techniques, either from the urine or with electroejaculation. And then ART procedures and lifestyle modifications. Anyway, obesity, all those factors have to be controlled in a patient with diabetes. So this is a good
one point regarding that.
Please.
Usually we advise IVF for me. One patient insisted for IUI, but I did not get result, even though count was normal in that patient. So I basically feel ICSI has to be done if you get sperm with retrograde ejaculation.
Yeah, that part is coming. So this is a good read for all the audience, a comprehensive guide to sperm recovery in infertile men with retrograde ejaculation. It's a retrograde review article which was published in 2022 in World Journal of Men's Health. So utility of electroejaculation versus surgical sperm retrieval. This question I just put it because if anyone has any experience with the electroejaculation in your clinic, can come forward and take up this one. Do anyone have the experience? I don't personally use electroejaculators. And high yield of viable sperm with surgical sperm retrieval. Surgical sperm retrieval methods such as testicular sperm extraction may yield higher quality sperm compared to electroejaculations. And sperm quality for ART, surgical sperm, surgically retrieved sperm provides higher quality sperm with the lowest DNA fragmentation. And electroejaculation can be useful for patients who are opting for IUI. And techniques for optimizing urine sample processing for sperm retrieval. Anything? Do anyone to add to this point?
I think that was clearly told by Rubin Shah, sir. I just want to add in few cases, usually for not like retrograde ejaculation, in those who cannot collect with, if you don't have routine electroejaculation, you can use the modified version of stimulating the penis with the small vibrators will be there. But only thing that you use in caution, because it can produce some irritation to the penis, not like the routine electroejaculation where the probe is kept correctly. And alternatively, in those cases with paraplegia, we can retrieve the sperm with the prostatic massage. Few sperms enough to do the ICSI we can get. I think Parshu can add to that, because we had done a few cases before. I think Parshu will be able to highlight that point, no?
Not basically retrograde ejaculation, but yes, in patients, especially paralytic patients who do not ejaculate. In those group of people, actually, we have found a prostatic massage and sperm retrieval quite effective. Even recently, we had a patient who was bedridden in Aster that called, and we went and got a lot of sperms actually just by only doing a prostatic massage.
Yeah, here coming to this point of retrograde ejaculation, the most important point which you have to advise your laboratory team, immediate processing, because there should be, it is very crucial to reduce sperm exposure to potentially harmful urinary metabolites. And bladder alkalinization on the previous day, centrifugation and washing of the sample immediately, and it should be as sterile as possible. And immediate dilution of the urine sample with sperm-friendly buffer can reduce toxicity, preserving sperm motility and morphology, and it's very useful for samples with high osmolarity. And double catheterization technique, introducing a double catheterization approach, catheterization before and after ejaculation, minimizes the residual urine and allows for cleaner sperm retrieval from bladder post-ejaculation. Fesi, are you there, Fesi?
Yes.
Can you just message Kokila that we will join for the meeting after this panel? Because
Yes,
she's
sir.
keeping on calling. Just
Yes,
message her.
Okay.
And feasibility of IUI with retrograde ejaculation. Fesi has already mentioned the challenges is with the sperm count and quality. And IVF-ICSI offers a higher success rate. And do anybody has experience with IUI in case of retrograde ejaculation? Dr. Usha, Indra, Anuradha, Shashibala, Raji,
No,
Parshram.
no, sir. No, sir.
No, not
All
yet.
of you go for IVF-ICSI.
Yeah.
Okay. And anytime, Fesi, shall we take up this case also if the panelists are not tired?
Yes. Quickly, we will finish this one more case.
Yeah, 32-year-old male with a BMI of 38 and a history of smoking and alcohol use, presents with mild oligospermia, high DNA fragmentation index, and borderline low testosterone levels. Couple has been trying to conceive for 2 years, considering IVF due to the poor results with the lifestyle. That means they are not, he's not able to reduce the weight. So don't come up and tell lifestyle modification, reduction weight. They came to you because they are not able to reduce the weight. So use of antioxidants, again, in this particular patient. Should DFI testing, guide treatment, and what threshold? And the role of ICSI versus conventional IVF in case of high DNA fragmentation, and when to consider TC or micro TC or alternative source of sperm in high DFI cases. So these are the effect of lifestyle modifications, antioxidants. So these are the things already mentioned a little bit. Just a moment. Tirupati, I'll join 15 minutes. Yeah, because I'm in a panel discussion. Sorry, the organizing committee meeting of the Justicon is happening. So, hello?
Yes. Hello.
Audible, no?
Yes.
Yeah.
Yeah.
Oxidative stress associated with a huge percentage of the male subfertility. And do you routinely do DFI testing, and will it guide your treatment? Because earlier discussion also we heard that DFI. Will you be people actually doing it? We will ask from one by one. Usha, I think Dr. Usha was doing. I think you were telling.
No, sir. No, we don't do it as a routine. This one has got all the risk factors for DFI.
No. I'm just asking a general question. Do you do DNA fragmentation in your clinic?
Only 2 cases we have done so far.
Only 2 questions.
I've been IVF for last 1 year.
Yeah. Reggie, medical college fragmentation?
No. We don't routinely do DFI.
Yeah. Then coming back to our star, Parshu.
We do DNA fragmentation, especially the primary reason we do it is for counseling the patient. And but all we
to counsel the patient from IUI to IVF, right?
Sir, if you don't know the history of DNA fragmentation, years ago, they actually grew up saying that DNA fragmentation is high. Don't do IUI, you have to only do IVF. That was the concept so many years ago. Okay, that was a whole concept where DNA fragmentation came in and we should do DNA fragmentation, things like that. Now, the whole idea here is I personally believe that already in a patient, like I think that this patient and the last patient that you had shown had very poor semen sample. So I know it's a controversial statement, but we believe that in most of these patients with already having a poor sample, also has a high possibility of having high DNA fragmentation. So by doing a DNA fragmentation, you are not going to really change your diagnosis or change anything in your treatment.
Yes.
The only place where
Yeah.
there is a role of a DNA fragmentation is this unexplained failures or normal looking semen parameters, but you're not getting pregnancy. Where these are the group of patients where probably where we end up seeing higher, where we feel that when you do a DNA fragmentation, where we can contribute or change or treat them by adding certain medicines.
Yeah, but here identifying the high DNA fragmentation will help us to counsel the patient to use the add-ons like special sperm selection techniques like
I'm coming to that, sir. So whenever we are having a DNA fragmentation, the only possibilities are looking at different kinds of adjuvants, like you do your microfluidic max, you use your Pixie, IMSI and things like that. See, but unfortunately, like we had discussed earlier also, we still do not have a single test which we can tell. See, that one sperm that we select, we don't know whether that sperm is having DNA fragmentation or not. So even when you're talking about max or microfluidics, we're getting only a cohort of sperms. We are not getting one sperm.
Actually, none of these sperm selection methods are not evidence-backed fully.
And
it is still controversial and it is still under research.
Sir, if at all we are using a procedure where we are selecting single sperms is either in a Pixie or in a IMSI, where we are actually selecting one sperm. But again, with IMSI, what are we looking at? We are looking at sperms which are not having vacuoles. We assume the sperms which are not having vacuoles is having a lesser DNA fragmentation. From the study that said that higher vacuolations are present when there are higher DNA fragmentation. But whether DNA fragmentation is vacuole, we don't know. So it's
that's why the vacuole seen in IMSI microscope, it's not clearly evidence correlated.
So we don't know whether that is a DNA fragmentation or not, but when we are removing it, we assume that it is having lesser DNA fragmentation. That's what is happening. So we do these additional techniques, but as you ask me if that is a first line of treatment, definitely no. A routine plain ICSI will always be the first line. If she fails or it's showing very high DNA fragment, things like that, we can add on some procedures like microfluidics or something which are literally easier and cheaper.
Yeah, here actually this meta-analysis clearly mentioned and subgroup analysis showed the impact of sperm DNA fragmentation on live birth rates amplified significantly in IVF but it become insignificant in ICSI, and the better quality oocyte with less exposure to oxidative stress may better preserve its ability in repairing the sperm DNA fragmentation. That's why a routine ICSI itself is sufficient in this type of patients. So when to consider TC as an alternative source of sperm in high DNA fragmentation cases, especially in the recurrent ART failure, that is the main part. And these are the main, the summary of the manipulations which we have to do, the reasons and the recommended types of assays and all those things. And I'm just winding it up as the time has exceeded. I think we could contribute a little bit to all the audience with regard to the information and summing up everything. And thank you all the panelists for adding a lot of things to the inputs. And if anyone has to make any additional comments, you can make and we will wind up.
Thank you all. Thank you, Kunji Moideen, and the panel members, especially Dr. Parshu, Dr. Reji, Dr. Shashibala, Dr. Usha, Yadav Madam, Indra Prasad, and Anuradha. I think we had a good mixture of an expert andrologist, Dr. Rubin Shah sir, and expert infertility specialists like Amit Patki sir, and a wonderful panel with infertility specialists, how they practically deal with the different situations. And it was wonderfully moderated by Dr. Kunji Moideen. I think already we have got more than 825 logins, and still till the almost till the end, we had more than 800 logins still there for the webinar. That is a good number. That shows the interest in people on specific topic. Like if not, rather than talking about whole of infertility, specific like in male infertility, we were our purpose of this webinar by Dr. Amit Patki sir is that specifically we will cover one topic. We had like 4 responders. This today we have male infertility, like that. Each one topic we'll be covering extensively, so that people will be enriched in their knowledge and it will be useful in their practice. So I think thanks all for till 9:45 all are logged in. So thank you. I think Dr. Manish and Nikhil can conclude.
Yeah,
Yes,
one
sir.
thing, just one thing. I want to ask you all, do
And
you
this
find
guy.
cases of genital COX in male also at your places? How frequently you are finding genital COX in male in your practice?
Kerala is less.
You can
Others,
see female genital cocks also.
female
We,
is
we
very,
don't
very
we
rare.
don't see both male and female. We never
Yeah.
see.
We don't see male and female. So
But in our circle, males hardly come for the examination. They
No,
don't even offer their physical examination.
so we usually insist that infertility, whenever somebody asks for consultation, it is a couple treatment. Both has to come, both has to be taken, and it is a couple treatment. We specifically tell, make sure they both has to come and see. It is a part of that. Unless we make it a routine, it is very difficult. And even if it is, I think Parshu will be, those whoever it is. Infertility, whether it is male gynecologist or female infertility specialist, as routine male examination is a part of the routine basic evaluation.
Yeah.
And the genital COX is pretty common in this part, Eastern UP, especially in Varanasi.
Eastern UP, very difficult to get the males
Many
examined.
cases of genital COX. That's why I asked.
Genital tuberculosis is common. Okay, thank you.
Thank you.
Thank you. Thank you so much, everyone.
Hello, everyone.
Lisa, for
Hello,
this
everyone. Good evening.
opportunity.
This is Pallavi More. I'm the
Everyone,
head
it
of
was very nice.
marketing with
Kunju sir,
UNS.
Kunju Maidin sir, it was very good.
Thank you
Thank you
so
so
much for
much.
making a
Thank you.
part.
Hello, everyone. This is Pallavi More. I'm the head of marketing with UNS, and I could not welcome you on this webinar when we started sharp at 7 p.m. But I really want to thank all the chairperson and the participants who are here. But I also want to thank Dr. Anu Agarwal and Dr. Fessi Lewis from a heartfelt thanks and from the bottom of our heart from the team UNS and also from ISAR. A big thank you and a shout out to our president ISAR, Dr. Amit Patki and Dr. Rupin Shah for really, sharing so many insightful datas and experiences. And I believe that the FAQ session also kind of helped us gain so many insights because this is such an evolving topic. And I totally echo with Dr. Fessi that if we choose specific topics, it is so much of interest, and the interest kind of just improves our trajectory of understanding. From Team UNS, this has been a learning curve for all of us. And I hope that this learning curve will continue from our side, and we will keep interesting topics with the help of Dr. Fessi and Dr. Anu Agarwal under the leadership of Dr. Amit Patki continued so that we have many more logins and we share the insights with all across India doctors to only enhance IVF practice in India and add value to the patient's life. So here's thank you so much from our side, and wishing you a very, very good night. Dr. Manish, if you would like to add, or we can conclude. Thank you so much.
Thanks a lot.
Thank
Thanks
you,
a lot.
UNS, for the wonderful platform and initiative in taking pain to organize things. Just telling the names and rest all the work we are doing. Isn't it, Dr. Anu? They are doing all the homework, everything has been done. So I was telling that where there must be some facility so that those who are logged in, those who could not attend completely can go back and see. Once you are registered, they can see all the recordings of the previous webinar, so that whenever time they can go and see. Whenever they recommend, somebody else can log in and see the previous episodes. There must be some. Tell your IT team to make arrangements for that.
We will ensure to
Good
implement.
idea.
Yeah.
So we are recording these
Yes.
webinars and posting it on the ISAR website also, sir.
Yes, these
Kindly share
webinars
the
are
link in the
recorded.
group also, no?
Sure. Yeah. We'll do that.
Absolutely. Absolutely, ma'am. We'll do it. And we take Dr. Fessi's suggestion. We'll just toss it with Dr. Amit Patki, take his permission, and we will share the link live for registration. So we actually understand who are the doctors who've logged in, and we count the number of doctors and share the insights geography-wise.
And we have to, usually it is in the first Tuesday. Only this time, because of Deepavali, we have to make it in the second Tuesday.
Yes,
And
please.
Dr. Rubin Shah was also not there, and many of the faculty was not there. So it will be as usual, first Tuesday. And there must be, even if you're once you're logged in one year month, you will be getting the reminders for the, you must be facilitated to get the reminder of the next month episode. And also, once you are logged in, you could be able to see the previous episode. Then it will be a good information sharing platform.
Certainly, sir, and happy to share that more than 800 logins. After a long time, I could able to see
That's
such
great.
huge logins, So thank you to you and everyone for the mega successful event today.
Okay. Thank
Thank
you.
you.
Thank
Thank you,
you.
Dr. Shashivala, ma'am, for that encouraging message for Team UNS. Thank you so much.
Thank you, Dr. Pooja, for staying still then.
Thank you so much,
Definitely, yes,
sir.
it was a pleasure. Definitely. Excellent session. Excellent session it was.
Very less discussed. These cases are very less frequently discussed.
Yeah, but I think the cases keep evolving, rare cases keep coming, and that's where the learning happens, and sharing is important, and which is why this webinar becomes even more important in this therapy area of IVF. And I hope that Team UNS will continue to serve you even better in the future forthcoming webinars. Thank you.
Okay, thank you. Good night.
Thank you all.
Thank you, sir.
Dr.
Thank you,
Anand.
everyone.
Thank you all.
For giving me this opportunity. Thank you. Bye. Good night.
Thank you. Thank you. Bye-bye.
Recording stopped.